hearing. My name is John Stinner. I'm from Gering, and I represent the 48th Legislative District. I serve as chair of this committee. I'd like to start off by having members do self-introductions, starting with Senator McDonald.
Mike McDonald, Legislative District 5, South Omaha.
John Stinner, District 48, all of Scottsbluff, Banner, and Kimball counties.
Robert Hilkeman, District 4, West Omaha.
Tony Vargas, downtown and South Omaha, District 7.
Myron Dorn, District 30, which is Gage County and part of Lancaster.
Assisting the committee today is Tamara Hunt, and actually to my left will be Liz Ruska. Our patient today is Jason Wendling. At each entrance, you'll find a green testifier sheet. So if you are planning to testify today, please fill out a signed-in sheet and hand it to the committee clerk when you come up to testify. If you will not be testifying at the microphone but would want to go on record as having a position on a bill being heard today, there are white sign-in sheets at each entrance where you may leave your name and other pertinent information. These sign-in sheets will become exhibits in the permanent record at the end of today's hearings. To better facilitate today's proceedings, I ask that you abide by the following procedures. Please silence or turn off your cell phones. Order of testimony will be introducer, proponents, opponents, neutral, closing. We ask that when you come up to testify, you spell your first and last name for the record before you testify. Be concise. It is my request that you limit your testimony to 5 minutes. Written materials may be distributed to the committee members as exhibits only while testimony is being offered. Hand them to the page for distribution to the committee and staff when you come up to testify. We need 12 copies. If you have written testimony but do not have 12 copies, please raise your hand now so that the page can make copies for you. With that, we'll begin today's hearings with LB 996. Good afternoon.
Good afternoon. Good afternoon, Chairman Stinner and members of Appropriations Committee. I am Myron Dorn, M-Y-R-O-N-D-O-R-N. I represent District 30, which is all of Gage County and southeastern Lancaster County. These past 2 years with the pandemic, we know various industries were hit hard, both financially and with regard to their employees. Yet there have been those businesses that have had additional challenges to continue to care for the people in the long-term care living facilities. I would like to introduce LB 996 to you. This bill would appropriate $5,462,800 and would appropriate $400 per licensed bed for Nebraska's 282 assisted living facilities from the Federal American Rescue Plan Act, or ARPA. These one-time funds would be used for recruitment and retention incentives for dedicated team members and for supplies and equipment necessary for infection control, such as personal protective equipment and testing supplies. Even though this is a one-time funding, the ability to offer these incentives will make a difference during a time when facilities are experiencing staffing crisis. I would like to thank the employees of the assisted living centers and so many others who continue to provide care to those residents in these facilities. I will be followed by other testifiers who can offer specific details on the cost increases experienced by assisted living facilities related to the pandemic. With that, I would be happy to answer any questions you may have.
Any questions? And they've got the administration half and half, general funds, as far as administering the program.
I did not.
In your fiscal note, it does have, I think, a split between general and what the,
And ARPA.
yeah.
Okay.
I believe that's what they put down for administrating the funds. So
Yes.
anyhow, I'm
Yep. No,
just making note of that so that
Okay.
we have it on the record.
You bet. Thank you.
Okay?
Yep.
Good afternoon.
Good afternoon, Senator Stinner and members of the Appropriations Committee. My name is Jaylene Carpenter, J-A-L-E-N-E-C-A-R-P-E-N-T-E-R. I'm the president and CEO of Nebraska Healthcare Association. On behalf of our 238 nonprofit and proprietary assisted living community members, I'm here to testify in support of LB 996 to appropriate $400 per assisted living licensed bed from the American Rescue Plan Act. We'd like to thank Senator Dorn for lending his support and recognizing the financial and human impact of the COVID-19 pandemic has and continues to have on our state's assisted living facilities. These funds would aid our facilities in providing recruitment and retention bonuses for team members who have been healthcare heroes on the front line. The funds would also help the increased cost necessary to protect the health and safety of our residents. As a congregate living space rather than a healthcare facility, assisted livings were uniquely impacted by COVID-19. Due to the age or the disability of the Nebraskans who reside in assisted living facilities, they're an at-risk population, and as such, every effort had to be taken to protect them. When a facility experiences an outbreak, and just as a reminder, an outbreak is defined as either one positive resident or one positive team member, a facility experiences a significant increase in their cost. For example, they need to offer hero pay, they have an increase in paper product uses for in-room meals, infection prevention supplies, gowns, gloves, masks, testing, cleaning supplies, and others. I would also like to note that in the last month, Nebraska's long-term care facilities experienced the highest number of outbreaks since the beginning of the pandemic. So while an unpleasant thought, the reality is our assisted living facilities will continue to have outbreaks and continue to need to manage those COVID-19 outbreaks in the future. Following me, you will hear from providers who have experienced this firsthand. Thank you for your time, and I'm happy to answer any questions.
Any questions? Senator Erdman.
Thank you, Senator Stenner. So you said they had the highest number of outbreaks. Are most of these people vaccinated?
So yes, I don't have the specifics on the assisted living residents and team members, but yes,
So they maybe have the booster as well?
I'm unaware.
Okay. So have we lost any assisted living facilities since the pandemic started that have closed?
Yes, we have experienced assisted living closures since the beginning of the pandemic. Get you specifics on how many.
Okay. Thank you.
Yep.
Additional questions? How many assisted living facilities do we have?
There's roughly 280 across the state.
Okay, in a bed means one, for an example, if two people are living there, a bed means that would be two people
Correct.
that we would allocate the funding for.
Yes.
So each bed.
Every bed,
Okay.
each individual.
Just wanted to make sure I understood that. Any additional questions? Seeing none, thank you.
Thank you.
Good afternoon,
Good
Senator
afternoon.
Sinner and members of the Appropriations Committee. My name is Tracy Lichty, TracyLichti, and I'm President and CEO of Newcastle Retirement Center in Omaha. And I serve as the chair of the Nebraska Assisted Living Association. Newcastle is the largest nonprofit assisted living in Nebraska and has served the community for over 48 years. We serve over 200 residents, and currently we only have about 150 residents. Newcastle employs 120 employees at this time, which is a reduction of about 15 employees. To best serve our residents, we need at least 135 employees. I am here to testify in support of LB 996. LB 996 appropriates American Rescue Plan Act funds to Nebraska assisted living providers to recruit and have retention incentives for our team members, plus provide assistance with costs of necessary supplies and equipment. These funds are vital to sustaining the livelihood of Newcastle. These additional one-time funds would allow us to offer higher on incentives, retention benefits. We're also always looking for creative ways to have opportunities to join our team. We're not trying to just stand still in this. We're looking at an opportunity through vocational rehab to successfully join our team for other parties, such as folks that have some disabilities that could still actively work. So we're looking for other opportunities. But with the LB 996 approval, we would have resources to cover the costs for initial training And as a part of our overall recruitment strategy, this is something we're looking for. These dollars could make this partnership happen and open the door to many folks to fulfilling and having a fulfilling job or even transferable job skills in the future. Newcastle, it needs an avenue to increase their employment pool. From 2020 to 2022, we have seen an increase in our payroll cost of $775,000 due to overtime and additional costs for recruitment and retention. Plus, we have experienced an increase of $32,000 in supply costs for PPE or disposable for meal service from 2020 to 2021. We foresee an increase in all of this still in the year of 2022. So I thank you for your time and consideration for LB 996, and I would be happy to answer any questions.
Questions? Seeing none, thank you.
Of course.
Afternoon.
Good afternoon, Chairman Stinner and members of the Appropriations Committee. My name is Jeff Fritzen, Jeffffritzen. I'm the Executive Director at Crest Retirement Center, and I'm here today as a board member of the Nebraska Healthcare Association. Crest Retirement Center is located in Adams, Nebraska, District 30. We operate as both a nursing home and an assisted living nonprofit provider. We have around 95 team members caring for 40 nursing home and 20 assisted living residents. 40% of our population is paid for by Medicaid. We were one of the first buildings in the state to experience a COVID outbreak, and I can tell you, as a building that operates both sides, the COVID impacts operate mostly the same way, no matter what, if you're an assisted living or a nursing home. The PPE requirements are the same, the isolation procedures are the same, the staffing needs that are affected, assisted livings are just about the same as far as trying to implement all the infection control procedures. So all those have increased the cost during the pandemic. Some examples: when a resident currently has COVID, the state ICAP team and some of the state experts require us to have them isolated for 10 days. That means 10 days that staff are wearing gowns, goggles, gloves every time they enter the room. It means bringing food and drinks and all those in containers that are disposable. So a large increase in cost for those 10 days for caring for that individual. And then also you're testing then staff and other exposure residents that might have been around them for the next 7 to 10 days. So a lot of things happen in a building when there's a COVID positive person. Also, though, there's also experiencing costs just when there's not an outbreak. So if there's not an outbreak in the facility, you're still having PPE costs, testing requirements for employees that receive the exemption. You have other increased costs as far as cleaning supplies and screening and making sure you have staff to do all those things. So in the end, assisted livings are receiving a lot of increased costs through the pandemic. And as I said earlier, I wanted to touch on, you talked about how COVID outbreaks are its highest point. We recently have had this week 5 residents test positive. All were vaccinated, all were boosted, and they all tested positive this week. So to answer your question, Senator Erdman, in our facility, we just experienced that. So I thank you guys for your time and consideration today. I'd be happy to answer any questions.
Senator Erdman.
Thank you, Senator. Thank you for the answer to that. So you have 20 people, 20 residents in the assisted living, correct?
Right,
And the bill says they're going to get $400 per licensed bed.
right.
How many beds do you have as a full capacity?
We have 35 actual licensed beds.
So then you'll get 35 times the $400,
Correct.
about 14,000 or something like
Yep.
that.
Yes. 17.5 or yes.
35.
Yeah.
Okay.
Yep.
Thank you.
Yep. Thank you.
Additional questions? Seeing none, thank you.
Thank you guys for your time.
You still.
Additional proponents? Any opponents? Anyone in the neutral capacity? Seeing none, would you like to close, Senator? Senator waives his closing. We have 25 letters of support, 1 in opposition, and that concludes our hearing on LB 996. We'll now open with LB 1055. Senator McDonald.
Thank you, Senator Stinner, members of the Appropriations Committee. My name is Mike McDonald, MIKEMCDONNELL. I represent Legislative District 5, South Omaha. I'm here to introduce LB 1055. Nebraska nurses have been on the front line since the start of this pandemic, and they have played a significant role in fighting COVID-19. But our nurses are exhausted and many are burned out. They are experiencing physical, mental, and emotional stress. The pandemic strained many facilities and were already short-staffed prior to COVID-19. Nurses are now considering retiring early, and many are leaving the profession altogether. Nebraska will experience a workforce shortage of 5,435 nurses by the year 2025. The shortage of nurses affects both Nebraska's physical and economic health. The lack of nurses to care for patients impedes the ability of our communities to attract and retain residents and businesses that employ them. It is imperative we act now. We must protect health and safety of our frontline nurses. That is why I'm introducing the Frontline Nurses Premium Pay Bill. LB 1055 will appropriate $50 million from the American Rescue Act plan. It will allow hospitals and federally qualified health centers to award premium pay bonuses to nurses who have been on the front lines during the pandemic. This funding will ensure that our nurses will be adequately compensated for their tireless and courageous work throughout the pandemic. I think we all have had a story about a family member, a neighbor, a friend that has suffered because of the pandemic. And I believe all those stories would come back to the care of a nurse in a facility. And prior to the pandemic and the great work that nurses were doing, but also they were getting stretched thin at that point. With the pandemic, it put them over the top. And the nurses that are here today are extremely passionate about what they've gone through. And we're trying to find a way to say, here, we would like to give you some compensation for the courage you showed during the pandemic, and thank them for all the care they've given to our family, friends, and neighbors. I'll take any questions.
Any questions? Seeing none, thank you. Afternoon.
Good afternoon, Senator Stinner and members of the Appropriations Committee. My name is Virginia Wolking, VirginiaWolking, and I am a registered nurse at Children's Hospital and Medical Center, and I work on the 6th floor medical surgical unit. I am here today to testify in support of LB 1055 on behalf of Children's, the Nebraska Hospital Association, and the Nebraska Chamber of Commerce. Throughout the pandemic, nurses have been asked to shift to widely variable swings in patient volumes and acuity. In the beginning of 2021, we were redeploying staff and asking people to take paid time off because patient volumes were so low. Due to the low volumes and uncertainty of the pediatric healthcare environment, not all vacant positions were refilled. Both of these factors cause economic stress on us nurses. Fast forward a few months to July and August, when children's patient volumes increased significantly. In places like the emergency department, volumes doubled. Inpatient days were up 20%. Now, in 2022, patient volumes and acuity remain high and nurses are in high demand, not only in Nebraska, but across the world. At Children's, we find ourselves competing for a very small pool of healthcare workers, along with every other hospital who is equally as short-staffed. To highlight the significance, Children's has only been able to replace 40% of the nursing workforce lost in 2021. And it's not just nurses, it's across all of our services: pharmacy, radiology, environmental services, food services, to name a few. That adds exponentially to the stress because nurses rely so much on these team members to provide excellent care. Nurses are the glue that makes sure that no matter what discipline is short, the patient gets what they need. Nurses are making sure that patients are transported to CT or MRI, the trash gets emptied in the room, the secure entrance of our patient unit is monitored in addition to all of our regular nursing duties. We go above and beyond what is expected, and we are trying so hard to provide the best care possible to the kids and their families. When we nurses are stretched so thin and do not have time to ease a parent's fears or make a child laugh, that takes away from the art of nursing and what we enjoy most about our work. Since August, nurses at Children's have been working extra shifts to meet patient demand. We even require our nursing managers and educators to pick up clinical shifts, and yet we are still short. As the safety net provider for all children across the state, we are used to complex care, but the children we are seeing today are sicker than ever before, adding additional pressure. We nurses leave each shift worrying that we didn't do enough for our patients and feeling like we were only able to accomplish the bare minimum. Nurses are people who have chosen patient care as our passion, and when we feel like we are not making a difference, it weighs heavily on us. At Children's, we recognize the toll the pandemic has taken on our staff. Being the only freestanding children's hospital in the region, the one-time ARPA funds proposed in LB 1055 will greatly assist us in our efforts to retain the highly specialized pediatric nurses so we can continue to improve kids' lives and serve our community. I know I speak for my colleagues across the state when I say thank you for your consideration of retention bonuses for those of us who have served at the bedside for the past 2 years. I'm happy to take any questions.
Questions? What's the attrition rate and turnover rate for nurses at Children's? Do you have any feel for that?
I don't have to, I'm happy to follow up with you on that, but I'm curious myself to see how that has changed over the past 2 years.
I think that's an important piece of data. Senator Clements.
Thank you, Mr. Chairman. Thank you, Ms. Wolking. You said you've only replaced 40% of the nurses who were lost. How many were lost due to not being vaccinated?
I don't know that exact number, and I will say I'm speaking only for myself now and not as a proponent of Children's, but I don't know that we have lost any because they have been removed from employment due to not being vaccinated.
Okay, thank you.
Just one other question is, is Children's employing a lot of the traveling nurses?
Yes, and it's been necessary because we've lost so many staff members.
What do you think in terms of percentage of your staffing is made up now of traveling nurses?
I don't know a percent. The last I've heard, as far as the number, I think we had 28 staff nurses. The floor that I work on, I know has now 5 staff nurses or 5 traveling nurses. And it's been necessary to keep us going. But I can also say that working with people who are travel nurses are competent and skilled, but they're not oriented to our hospital. And so that's another source of stress because we're helping them out and showing them where supplies are and things like that to get them oriented.
They're also expensive. Senator Hilkeman.
How many of the people you've lost have gone on to work for these traveling nurses?
I can only speak anecdotally on that. I know of quite a few, but I also know of nurses who were nearing the end of their career at the beginning of the pandemic, and this was sort of what pushed them over the edge to retire. But that leaves a huge hole for us who are used to learning from incredibly skilled people who have worked at the bedside for sometimes 30 and even 40 years. So we're left with that hole without having that institutional knowledge and skill and experience.
Thank you.
And Senator Erdman brought up the fact that the traveling nurses don't qualify for this, but I just wanted to get a sense of what that extra cost is relative to healthcare. So, and what the practices now are moving more toward traveling nurses. In any event, any additional questions? Seeing none, thank you.
Thank you.
Afternoon.
Good afternoon, Senator Stinner and members of the Appropriations Committee. My name is Linda Stones. I'm a registered nurse and practicing for over 30 years. I am here today on behalf of the Nebraska Board of Nursing in support of LB 1055. The Nebraska Board of Nursing and the Nebraska Center for Nursing closely watch the nursing workforce in Nebraska. During this last renewal period, which was 2021, Nebraska experienced our first decrease in the nursing workforce. This was the first time in 20 years that Nebraska saw a decline, and the decline was about 2,600 or 9.5% reduction in our workforce. Pre-pandemic, nursing projections indicated that Nebraska would face a nursing shortage of over 5,000 nurses by the year 2025. We are concerned that the pandemic has only exacerbated this workforce shortage. As we consider the shortage, there are two elements that we want to bring to your attention. One is recruitment, and the second is retention. Our nursing colleges really stepped up to the plate. In 2020, we're actually educating 79% more nurses than they did in 2003. However, we have seen a reduction in enrollment since the pandemic. As a member of the Board of Nursing, we're concerned about public safety. Not having enough nurses to care for our patients puts patients at risk. A very large study by Dr. Aiken and other researchers documented that a higher nurse-to-patient ratio increases the odds of patients' death and failure to rescue. Based on the Nebraska workforce data published by the Nebraska Center for Nursing between 2018 and 2019 and then 2021, Nebraska lost an average of 1.5 nurses per 1,000 people. From the same 2021 report, 6.9% of the RNs and APRNs report being, quote, very likely, unquote, to leave their employment over the next 12 months. Nearly 1,000 nurses between the ages of 24 and 55 reported they were very likely to leave their employment over the next 12 months as well. According to the 2021 RN APRN renewal survey, we have 9 counties in Nebraska that have 0 nurses or APRNs working in them. Now, LB 1055 is a small token of appreciation for the work our frontline staff have done during this horrific time in our country. We know that monetary doesn't always retain nurses, but appreciation is one of the strongest forms of influencers for our employee retention. And LB 1055 will bring to light the appreciation that Nebraska has for the nurses who have worked during this pandemic. We also hope that 1055 shines a light on the challenges of retaining nurses. We hope that this will open a dialogue to allow nurses to have a voice in the system, rules and regulations and institutions that create frustration and impede the nurses' calling to help others. LB 1055 is a stopgap measure to show the nurses they are appreciated. We hope that it will be the thing that keeps them hanging on while we work on some long-term retention strategies. I would like to thank Senator McDonald for introducing this bill and would like to ask the committee to support LB 1055. If you have any questions, I'll be glad to answer them.
We need you to spell your name.
Oh, and I even have it written and I didn't. Lindastones.
Thank you. Additional questions? Seeing none, thank you.
I hope somebody's got search parties out for those two. Just 1 second. Yeah, we don't need that on yet. Whatever.
Good afternoon.
Good afternoon. Can someone turn that off and then we'll turn it back on? But now I'm ready. No big deal. It's just, I gotta, okay, so my name, thank you, Chairman Stinner of the Appropriations Committee and committee members. Thank you for, my name is Joey Litwinowitz, WINOWICZ. And what I would like to say is that I support this bill without any doubt, wholeheartedly. I would also, I don't know if it includes CNAs and health aides, because I know a COVID warrior CNA worked on the 6th floor at Bryant. And I just hope that these get equally included, because it turns out when cares are actually done, well, in a COVID unit, I think it's probably pretty even. But for example, I think so you have the frontline warriors that are also CNA home health aides. They come and visit people that are at risk. And so the home health agencies, the one I was at recently had to stop taking Medicaid waiver because, provider rates. And so maybe we can approach appropriate some federal funding for this. I don't know how that works. But I was dropped, and they said I had 30 days to find a new place. And that's like 5 minutes. If you're thinking about jumping a bunch of people out of one company. And in fact, I had a visit I couldn't fill, only one smaller one for a long time. In fact, and the only reason I really was able to be okay, I think, is because one aide left with me to go to where I went next. She was like my sister, it turned out. And so I had another person that was, that was able to, that had previously given me a lot of cares, that was able to re-engage. But so we have the frontline CNAs that definitely, from my experience, they do all the cares, at home health. The nurses show up and they do great work, and sometimes they're needed to do things, but they're stretched thin. So all the cares and all the interactions, I mean, you could say just completely are done, at least in my experience, by the CNAs. And so I just don't want this, I think everybody should get a part of this money, and especially the ones that, for example, in the home health industry, I think, I have a lot of hands-on cares with bathing and getting dressed and stuff. And so at the beginning of this, it just, well, I think I'm going to stop. And that's the only point I came to give today. And because, CNA, these home health agencies are competing with Chipotle and Costco. And some of them are going to go out of business. In fact, like 2016 to 2019, for example, there was no increase. And then since then, it's been 2%. And you can't renegotiate with the state. So if you've been in business for years, like I know of one place, the lady had to actually shut that company down because she couldn't negotiate. And she had paid the price because she had been in business too long. And what really pisses me off is that it's not even tied to inflation. These companies are on the verge, just like everybody else. And I think, foster kids, developmentally disabled, I put them ahead of me, but I really don't want to lay in bed in my own feces for too long. And so I just hope everybody gets a part of something. And I'm just really passionate about it, and thanks for listening. And if there are any questions, I'll answer from my point of view.
Questions? Seeing none, thank you.
All right, thank you.
Good afternoon.
Good afternoon, Mr. Chairman and members of the Appropriations Committee. My name is Dr. Carrie Wade, K-A-R-I-W-A-D-E, and I am a registered nurse and president of the Nebraska Nurses Association. I'm here today to share the Nebraska Nurses Association's support for LB 1055 to appropriate federal ARPA funds to premium pay to Frontline Nurses. I have been a registered nurse in Nebraska for 22 years. I've never seen a more abrupt and intense shift in a profession than what has occurred over the past 2 years to nurses. On March 1st, 2020, nurses across Nebraska went to work as they have any other day. They wore scrubs, communicated with patients and colleagues with smiles, and felt confident in the work they were doing as their education was based on science and what was known about caring and treating individuals of all kinds. Just a couple weeks later, a dramatic shift occurred. COVID-19 had entered Nebraska and a state of emergency was declared on March 13th, 2022. Frontline nurses were now required to be fully covered in personal protective equipment known as PPE for the entirety of their shift. A face shield, N95 or equivalent respiratory mask, a disposable long sleeve gown, gloves, and when caring for a respiratory patient, a powered air purifying respirator, which is one of those helmet-looking things with the vacuum hose attached to the waist. I ask that you imagine yourself for a minute showing up to work and now having to do your job covered head to toe in hot, constraining protective attire with fear of knowing you could be infected by a disease at that time we knew little about and transmit it to your loved ones. While much of the world shut down and transitioned to working remote and avoiding contact with other people, nurses continued to show up in person, caring for the patient they serve at the bedside. Even with all the fear and unknowns that were among us when the pandemic hit, nurses never missed a beat. This week is the 100th week since the emergency declaration was declared in 2020. That's 704 days. Nurses continue to show up. Our frontline nurses in Nebraska have never had a break in this time. They haven't worked remote. They have shown ceaseless dedication to their profession, their patients, and their community. While the emergency declaration ended July 30th of 2021, COVID-19 did not end. Just 4 weeks ago, hospitalizations for COVID-19 peaked in Nebraska, and many hospitals entered practice to crisis standards of care. Nurses are taking on extra shifts, mandated overtime, working shorthanded, and caring for more patients than they can handle. They are exhausted emotionally, mentally, and physically. After 704 days, 100 weeks, it continues. The U.S. Department of Treasury has released the rules governing implementation of the American Rescue Plan Act, Coronavirus State and Local Fiscal Recovery Funds. Premium pay for frontline workers is identified as a direct connection to the type of initiative these funds should be considered for. I can't think of a more deserving group to receive premium pay than the frontline nurses of Nebraska for the sacrifices they have made and continue to make for our hospitals and communities over the past 2 years. LB 1055 is the priority bill for the Nebraska Nurses Association this year. Providing premium pay to our frontline workers would provide a much-needed morale boost and sign of appreciation to the dedication and steadfast commitment the Nebraska frontline nurses have made during this pandemic. Thank you for the opportunity to be here, and thank you to Senator McDonald for introducing LB 1055. Happy to take any questions.
Any questions? Senator Clements.
Thank you, Dr. Wade. Do you have a proposal with how much premium pay per nurse you expect?
From the calculations that I've heard from the Nebraska Hospital Association, they anticipated that if there's approximately 20,000 nurses who were to receive this pay, that's an estimate, it would be approximately $2,000 per nurse.
And are only registered nurses included in this bill?
I don't believe it's just registered nurses. I would have to double check the wording exactly on that.
All right, we can
It's
find
in
that.
frontline nurses.
Thank you.
Additional questions? Seeing none, thank you.
Good afternoon, Chairman Stinner and members of the Appropriations Committee. I am Andrea Skolkin, ANDREASKOLKIN, and I am the Chief Executive Officer of One World Community Health Centers with our home in South Omaha. But I'm also here on behalf of the 7 health centers in Nebraska and the Health Center Association. We serve over 107,000 patients annually in the state of Nebraska, and we see patients without regard to their insurance status or ability to pay, and we are an integral part of the safety net. In 2020, over 30% of Nebraska's uninsured people received care at FQHC, as well as 12% of all Medicaid enrollees. LB 1055 would create a fund to pay grants toward premium pay for frontline nurses for the federally qualified health centers and hospitals. This bill is crucial to ensure that there is an adequate nursing workforce in Nebraska. There is a shortage of nursing in Nebraska, as you heard. 73 of Nebraska's 93 counties have fewer nurses than the national average. At current rates, it's estimated Nebraska will be short 5,500 nurses by 2025. COVID-19 has made the situation worse as burnout remains a significant issue, especially in health centers along with the hospitals who have been on the front line of the pandemic. To date, health centers have provided 64,700 COVID tests and vaccinated 42,875 individuals. Our patient population is predominantly low income, uninsured or underinsured, often having significant language barriers, making health center patients some of the most difficult people to reach. Our patients also have transportation issues, lower health literacy, less access to effective PPE, and work on the front line in essential jobs with more exposure and fewer worker protections. One World has played a critical role in the COVID-19 response with testing and caring for 10,000 positive COVID patients and implementing door-to-door vaccination in South Omaha. And it's remarkable to us that the zip code in which our home is, that the vaccination rate is one of the highest in this state. It is because of the hard work and perseverance of our exceptional nursing staff that has played a critical role in our ability to respond to the ongoing needs of the pandemic. And I just want to share a brief, not too in the past story. We had a young pregnant mom who was diagnosed with COVID. She was in her 20s and it was her first pregnancy. She called into our triage nurses several times, each time in worse shape than the last, but still within the normal ranges in oxygen saturation. But 3 different One World triage nurses worked on her case and followed her care and sent her to the hospital 3 times due to decreasing oxygen levels. This young mom had an oxygen saturation rate that appeared normal for non-pregnant adults, but our nurses were very concerned for the baby. She continued to feel short of breath and weak. We continued to work with her and the emergency room where the patient was finally intubated, put in ICU, and the baby was born early, spending time in the NICU. Our nurses were able to recognize the warning signs and advocated for this patient. It can be very hard once a patient has gone home to send them back to the emergency department, but our nurses were able to do this. As you can imagine, this situation was very stressful, along with the day-to-day frontline exposure to COVID. We want to make sure that we still have our healthcare workers when the next pandemic or epidemic hits. If too many nurses suffer burnout, we will not have them, and we will be much less prepared. The premium pay from LB 1055 is important to help retain the crucial safety net workforce. It is also essential to send a message to our frontline nurses who have struggled and risked their exposure while getting us through most of this pandemic. We want to show them appreciation. I'd like to thank Senator McDonald for introducing this important legislation and encourage the committee to advance this bill, and I'm happy to answer questions.
Any questions? Seeing none, thank you.
Good afternoon,
Afternoon.
Senator Stinner, excuse me. and the Appropriations Committee. My name is Lacey Ferguson, LACIE-FERGUSON, and I've been a nurse for 5 years. 4 of those years, I've spent my time on the intensive care unit. I'm here today to speak to you in support of LB 1055. The first 2 years of my ICU career, I could count on 2 hands the amount of people I coded. When I say coded, it's when their heart stops or they stop breathing. We try to restart their heart or supply oxygen to them. On the onset of those codes, they were expected due to the patient's diagnosis or injury. Going to work, I didn't have a looming worry over me of who is going to die today or how short are we working today. But since March of 2020, that has all changed. Within the last 2 years, I cannot count the number of codes that we've had, often in full, that full protective personal equipment that we've spoken of. And I cannot count the amount of times we've tried to prevent at all costs of coding that individual because it's been so frequent within our daily work. The time to decompress between codes or a crashing patient just isn't there anymore. We have to declare that that patient has passed, place a heartbreaking phone call to the loved ones, and move on to the next patient that is begging to breathe to do it all over again. Or if the patient is lucky to avoid a code and become comfort cares, and they can spend their last moments of their life seeing their family through a video call as we hold their hand as they die. The level of acuity of these patients that we've cared for the past few years have significantly changed. They may have an active COVID diagnosis, or they'll be out of isolation or have a past diagnosis from months before. Regardless of that diagnosis, their care has become more complex in more ways than one. What went from being 7 days on a ventilator through an endotracheal tube, which is a hard plastic tube that goes down your airway via your mouth, down to your trachea here. 7 days, that past standard, you would typically opt into a tracheostomy. That would be a simple procedure for most physicians to a direct airway into their trachea so they could be more comfortable on that ventilator. Now, individuals are on that ventilator for up to 50 days with that hard plastic tube due to the high amounts of oxygen that they're requiring. And due to the high amounts of oxygen, we are having to place them in a prone position, which is laying flat on their stomach, face down. Mind you, with several tubes coming out of their body, and as we flip them, trying to not dislodge those tubes, bringing in more staff at that time to make this arrangement for this patient so they can ventilate better and exchange oxygen. All that requiring a special set of skills. This all continues when they're out of isolation, so may we not be wearing that personal protective equipment anymore, but they still are some of the sickest patients on the floor that are staying with us. Their lungs are completely scarred from the COVID diagnosis, and then their lungs begin to cause their other organs to fail. We bring in machines to their bedside to act as external organs for these patients to reverse the damage that was caused by COVID-19. Mind you, bringing all these machines in and having that special skill set that we need, staffing has been an issue with the team being sick, overworked, and being pushed thin. It's a constant puzzle making sure that we are putting patients in the correct order to provide safety and adequate staffing for each patient, because that's our utmost importance. With this emotional strain of the pandemic, this took me to therapy. The constant conversations with families of we've done everything we can, or this is all we can do, followed by the patient's families still not believing that their loved one had COVID-19. And yelling at you through the phone would lead most people to therapy, especially when you're trying to have the best support, knowing that their loved one's outcome is going to be poor. The flashbacks of being in a room, coding one patient, knowing full well that patient next door is actively dying. We did what we had to do for our patients and for our community, and we will continue to do so. If it wasn't for therapy, I wouldn't be nursing today because of the toll, as you can see, it's put on me emotionally. But I'm strong in my faith, and I believe all things have a purpose, and that purpose is for me to be here today, to have a voice for myself and for my peers, as you've heard from beside me. So please listen to our stories and know that this is just a small glimpse into what we live today and what we have lived for the past 2 years. Others throughout Nebraska on the front line are living it too, showing up each day to take care of our fellow Nebraskans with compassion and grit. Thank you, Senator McDonald, for introducing this bill, and please have support for LB 1055 to keep our nurses going.
Thank you. Questions? Seeing none, thank you and thank you for what you do.
Good afternoon, Senator Stinner and members of the Appropriations Committee. My name is Caitlin Rogge, K-A-I-T-L-I-N-R-O-G-G-E. I've been a registered nurse for almost 5 years, and I'm here today to speak in support of LB 1055. The COVID-19 pandemic has had an incredible impact on the healthcare system and specifically nurses. Today, I want to share my story with you. I remember each person I have lost during my nursing career. As a nurse in the intensive care unit, death is not new to me. However, COVID has amplified this experience for me, surpassing the normal loss in ICU nurse experiences. I have seen many patients lose their lives to COVID and many that have been forever devastated by this disease. Caring for a severely ill COVID patient requires more critical care resources than any other patient I have seen. This creates a long and stressful day for that nurse and a constant fear that something detrimental would happen. This heightened anxiety wears on the nurses caring for these patients. There has never been another respiratory disease that draws out death like this before. It is heartbreaking to watch someone suffer and know that there is nothing we can do to help them. We watch these patients struggle to breathe and slowly waste away. With each loss, it is getting harder to compartmentalize the things that I have seen. I carry many of these experiences with me and did not realize the emotional aftermath it had on me until I began having trouble sleeping and having anxious episodes nights before I would have to work the next day. There are moments of the pandemic that will always haunt me. I can close my eyes and I can see his struggle. I can hear his alarm at the nurse's station as I rush to his room. I can hear the helplessness in my voice as I call to help for my coworkers. Every single one of my coworkers knew the gravity of the situation that was unfolding. There was nothing else we could do to save his lungs. The patient had been fighting on our unit for months. Tears triggered and began to cloud my vision as I accepted what was happening. I felt utterly helpless. My brain was in survival mode and I tried my best to keep it together because I had to. The panic in his eyes is forever ingrained into my memory. Emotions overwhelmed me when the pulmonologist told him he was dying and tears welled in all of our eyes. Losing him was something I was not prepared for as I felt like I lost a friend. The ICU was eerily quiet the rest of the day and I couldn't look at his room for weeks. However, the support I felt from my coworkers was unmatched. We supported one another and pushed on. When my anxiety creeps in, I close my eyes and I focus on my breathing. I often find myself thinking, how am I able to do this? I lean on my coworkers who surprise me with coffee. I lean on my husband for making me dinner after work and understanding my edginess. I lean on my family and friends who check in on me often. And I lean on my dogs who greet me after a long day with their unconditional love. I am surrounded by people who love and care for me. As nurses, we try to be strong for others, but there comes a point in time where we cannot. We need to care for ourselves first in order to be able to care for others to the best of our abilities. Nurses are carrying the stress, pain, and weight of COVID in our hearts. It has taken a toll on our minds, and many of us are struggling with our mental health. It used to be easier to leave what I saw at work and unwind at home. Now I cannot escape my job and the stress it places on my life. These past 2 years have been full of change, frustration, unknowns, and death. I've been blessed with a great nursing team and an organization that truly supports me, but there are others who struggle alone. I know that if I have struggled while having a very strong support system backing me, that there is an even greater need for many other nurses in our state who have lesser support. I have seen amazing nurses leave the bedside because of the never-ending stress the pandemic has placed on them. Many nurses are feeling run down and burnt out. The pandemic stress on nursing is no longer worth it for many, and they have found that they can make a better living doing something else that is not as emotionally draining. Without strong support of our nurses, our patient care will suffer in Nebraska. This bill will provide financial support for Nebraska nurses to better care for themselves and help them feel appreciated for their tireless efforts as the pandemic continues. LB 1055 will not take away the pain and stress the pandemic has caused. It will not fade the memories of the pandemic or slow my anxious mind. It will, however, send a strong message to my nursing colleagues and friends that Nebraska stands behind their nurses, that we are not alone, that our work makes a difference and people care about their caregivers. I want to thank Senator McDonnell for introducing this bill and to ask this committee to support LB 1055. Thank you.
Thank you. Questions? Seeing none, thank you very much. Afternoon.
Good afternoon. Good afternoon, Senators, Senator, and members of the Appropriation Committee. My name is Jennifer Ferris, Jennifferis. I'm a registered nurse with 20 years experience. I have worked in a float pool at my hospital, which means I do not have a home unit, but instead I work where there is the greatest need. My first time taking care of a COVID patient was September 11th, 2020. I've cared for patients on and off since that time. My colleagues who work in the ICU are seeing patient after patient die. I was thankful I was in the float pool, so I did not have to experience death every day I worked. Caring for a body after dying is a different process with COVID. After the body was cleaned and prepared, a rag saturated with oxycide, a disinfectant, was wrapped around the patient's face, and the entire body was placed in a white, big plastic drape and secured with red duct tape. Then the body was ready for the mortuary. I am thankful that I never had to do this. When I think to myself about this process and how many of my peers did this day in and day out, I get very nauseated. I want to share the story of a patient I will call Bob. The first time I met Bob, he wasn't my patient, but his nurse was busy, so I checked on him. He was on a BiPAP. This is bilevel positive airway pressure support at 100%. This is a mask that covers his nose and mouth, or could cover his entire face and pushes oxygen into and out of his body. The percentages changed based on the patient's needs. As you would expect, 100% is max support. Next step would be intubation and ventilator support. With BiPAP, he was not sedated and could communicate effectively with his team, but he could not eat or drink. When his oxygen level was high enough, we would switch him to a device called Airvo, which is a large bore nasal cannula providing oxygen and humidity in a heated circuit, which would allow him to eat and drink. The following weekend, I chose to care for him. He was still on max oxygen support without the ventilator. I got him to a chair. I did a bed bath. I brought him a cola without him asking. I told him I had prayed for him. Bob was touched. A couple weeks later, Bob was out of isolation, but he had moved to our other ICU. This time I found him intubated and sedated. The next day, he was going to have a tracheostomy placed. His daughter was at the bedside, and I told her I had taken care of him when he was in isolation and had prayed for him. She stated that he had told her mom about me, and they were both touched. Since COVID, I read obituaries and search for Google for my patients more frequently than ever before. Bob was one of those patients. When I searched Google, I found his obituary. This made me pause. I wanted to know more. But sometimes you don't know. During the past few years, what really stands out to me is how I've helped patients with their last times, the last time using the restroom, their last bites. When I shut my eyes, I always think of the patient I helped out of the bathroom for the last time. He was standing by the door, hanging in the door frame and grunting. His eyeballs were large. He needed oxygen. He took 2 or 3 steps and crumbled to the floor. His eyes remind me of the scene in the Titanic movie when the ship was going down and the passengers were floating in the water with their big eyes. This is the memory that still haunts me today. This was over 1 year ago. In late January, I decided to step away from the bedside. I will miss the direct patient care and the relationships I had with my patients. Although I'm not a bedside nurse anymore, I fully support LB 1055, and I hope you will too. I'm not alone. There are many more nurses who have stories like mine. Passing 1055 will send us a message of appreciation, of hope. Thank you, Senator McDonald, for introducing this bill. Senator Stenner and committee, I ask you to please advance 1055.
Thank you. Additional questions?
Yeah.
Senator Dorn.
You said you stepped away from the profession.
Just the bedside. I am still working at the organization that I work at, but an opportunity, a nurse was retiring and that needed to be filled.
Well, thank you for what you've done.
Thank you.
Good afternoon, Senator Stenner, members of the Appropriations Committee. My name is Nicole Hanson, NICHOLEHANSON, and I'm a registered nurse with almost 10 years of experience, all of which have been in the intensive care unit. I'm here today to speak in support of LB 1055. Pandemic fatigue among nurses is real, and it will be something that will be thought about, talked about, and felt for the rest of our careers.
While LB 1055 does not take away the strain nurses have felt during the pandemic, it does send a message of support to those showing up each day to provide compassionate care to our patients. I'm thankful for the opportunity to share my story with you today. While working in an ICU during this pandemic, we were introduced to medical treatments and situations that we had to learn and master quickly. Proning patients, turning a patient onto their stomach, required at least 3 nurses and a respiratory therapist to manage all of the tubes and lines while trying to prevent injury to the patient and staff. Utilizing combinations and sizable amounts of sedation and paralytics that we would have never considered before, because the patient's body would decompensate and use more oxygen than it had just by simply being awake. We had to get creative in managing the equipment that we had to access quickly, with IV meds, pumps, and ventilator modules outside of the patient rooms. Doing all of this and trying to maintain some sort of dignity for these patients who may have just enough consciousness to know that they were miserable and dying, and there was nothing we could do to change any of it. Our staff was running hard. Nearly every shift, providers and nurses had to decide if there was an ICU patient that might be healthy enough to move off the unit, as there was a sicker patient in the hospital needing that ICU bed. There were times, as a charge nurse, that I had no idea what we were going to do. I had no safe plan for the next patient and how they were going to get the nursing care that they required. I spent a lot of my shift off the unit responding to the rapid response calls and code blues on other floors, which left me not being able to be a resource to my team and assist on my unit. A unit where nurses were running multiple machines on multiple patients, including ventilators, dialysis, ECMO, and numerous critical IV meds. Now I'm going to add a spin to this. If you ask any ICU nurse, this is what they live for. The machines, the meds, the beeps, the managing of all the lines, the calls to the doctors, the more IV pumps, the better. Running labs and interpreting numbers and the how and the why, we love that. However, we love that as our normal, safe workload. We were adding so much onto our staff that this overwhelming sense of dread would come over you before your shift. Most of us have this as a new grad starting out. The unsure, please don't let anybody die today feeling. But now, as expert nurses, that nauseated feeling was back, only not because we didn't know what we were doing, but because we were unsure if we could keep up. The physical and mental demands were profound, a period of nursing that no amount of training could prepare you for, and we hope to never work through again. We had hours of mandatory overtime to compensate for our high patient volumes, daily messages from work begging for help, and the anguish it put on you knowing that your team was struggling, but you hesitate to answer because you don't know if you can mentally handle another shift. You don't know if you can mentally handle watching more family members cry through the iPad, telling their loved one to just hold on and stay strong while holding in the knowledge that they will surely die. You don't know if you can handle putting another tube in another orifice of another patient with the feelings of agony that you're prolonging suffering instead of providing a dignified end to this human's life. You don't know if you'll be able to bury your emotions enough to get through wrapping another deceased human being in a plastic bag and sealing it with tape for the mortuary. Red tape for a COVID patient, orange for a non-COVID. No matter how much death we may be accustomed to as an ICU nurse, nothing compares to wrapping a human being in a plastic bag. One thing you're sure of, though, is that when you come home after your shift, you will have nothing left to give your family or yourself. We even felt guilty venting to our spouses and family at the end of our shifts, like we usually did before, because of the emotional stress it would put on them. Many sought out professional help for our mental health. Some quit the profession altogether. Our profession became broadcasted throughout the world, and we heard everything from the term heroes, while people cheered and made signs as we entered our buildings, to negating our experience as a normal day, as this was just part of our job, and if you don't like it, switch jobs. I can tell you this, not one nurse in this profession would call themselves a hero, or could have been prepared for the mental and emotional toll this pandemic took on us, and all healthcare professionals for that matter. This was anything but normal working conditions, and we hope to never return to that state in our working lifetime. I will also tell you that nurses don't just switch professions. We take absolute pride in serving this community. Nursing isn't just a job, it's part of who we are. We cannot erase what we've had to see or to endure. It will not roll back time and the virus from our memories. It will, however, show a strong message to me and my nursing colleagues that Nebraska appreciates the role nurses have played in this pandemic. It will be a show of support and encouragement. I would like to thank Senator McDonald for introducing this bill. Thank you, senators, for listening to my story. Please support LB 1055.
Thank you. Questions? Seeing none, thank you very much.
Thank you.
Any additional proponents? Any opponents? Anyone in the neutral capacity? Seeing none, Senator, would you like to close?
Yeah, quickly, just follow up on a couple questions. Senator Clements was talking about the amount of money, and that was accurate. Most likely it'd be approximately $2,000. We also put in the bill, though, that it would be a max of $5,000. Also, the idea of a frontline a nurse is direct contact with the patients. So that's also defined in the bill. Now you look at the amount of money we're talking about, and it is an ask of $50 million. I don't think it's enough. I don't know if there is enough for what they've done, what they've sacrificed, what they continue to do. But for us to say, we appreciate what you're doing, we respect what you're doing, we're asking you to please continue. Don't change professions. Don't give up. We're here for you, and this is a show of our us being thankful. And it's a minimal amount of money, but it's us recognizing the sacrifice you've made. Any questions?
Very good. Senator Dorn.
Thank you, Chairman Senator. Thank you for bringing the bill and stuff. But when you say frontline, do you mean frontline in just a hospital, or is that other
Hospital or federally qualified facility?
Like a nursing home, or
If
as
it
long
falls
as they're
under
a
the-
registered nurse or higher, then that's a front. And they would have had daily contact with a patient, you're saying?
Yeah, we defined it in the bill that you have direct contact with the patient. So let's say I'm a nurse, but I've moved into the administrative side and I'm not having any kind of direct contact with the patient.
Then not, but like a Madonna.
As long as it's a federally qualified health facility.
Additional questions? Seeing none, thank you, Senator. We
Thank you.
have 5 letters of support, 1 in opposition, and that closes our hearing for LB 1055. We'll now open on LB 1066. Senator Hilkeman.
I will. Okay. There's gonna be many left here. I know it. I know it. I would remind committee members to put on 3 set of ears. Here's the beer for all the members of the committee.
Good afternoon, members of the Appropriations Committee. My name's John Stenner. For the record, it's John Stinnner, and I represent the 48th District, which is all of Scottsbluff, Banner, and Kimball counties. LB 1066 provides federal funding from the American Rescue Act of 2021 for access to behavioral health acute care beds in rural Nebraska and training and education opportunity for behavioral health workforce in Nebraska. This is a multi-part package. LB 1068, reference to the Health and Human Service Committee, includes some statutory changes to redefine the mission of Beacon to encompass the changes of this overall package. LB 1066 includes $5 million appropriated to the Department of Health and Human Services to provide grants up to $250,000 for capital costs related to the expansion of behavioral health acute care beds in rural areas where shortages exist. $28 million is appropriated to the University of Nebraska for Beacon to develop a comprehensive behavioral health internship program, a telehealth a telebehavioral health support program, COVID-19 specific behavioral health education and training, and support for provisional licensed behavioral health professions. This is how the breakdown is of that 28 million. 13 million will go to qualified internship programs for behavioral health trainees and supervisors to support successful completion of degree program and licensures. 10 million on a competitive basis will go to telebehavioral health programs designed to provide distance-based behavioral health services and proximal care. 3 million will go to a one-time training and education professional development opportunities related to the COVID-19 emergency for current behavioral health professionals and students to recruit and educate students in behavioral health training programs. And then 2 million will provide to support provisional licensed professionals who need additional supervision to become fully licensed. So that's kind of the breakdown of how we're going to break out that 28 million. This multi-part package stems from a working group comprised of behavioral health experts who gathered last interim to address the urgent and long-term needs of the Nebraska behavioral health care system. The working group concluded that there were numerous needs, but that unless we can address short and long-term workforce issues, there are a few goals that can be met. Using the federal and state funds in the most fiscally responsible manner, directing it to funds that funds existing programs with a successful track record will ensure a lasting impact across the state, guided by the recommendations of this group. The work group identified 4 priority areas to focus in on, number 1, starting the behavioral health workforce pipeline from high schools, provide proximal education opportunities such as community college, state colleges, and university systems. 3 is to remove barriers for students and provisionally licensed professionals with the use of paid internships and stipends to fill the gap when they cannot be paid for with services by employer providers, proximal training, and continuing education opportunities. The cumbersome licensing process was also identified, but it was something that we did not want to address in this short-term session. The provisions under 1066 also address option 13 and 14 identified by the Criminal Justice Reinvestment Working Group. Option 13 identified the need to increase incentives for students in Nebraska to pursue careers in behavioral health to provide care in designated shortage areas across the state. Option 14 identified the need to increase access to telehealth services for court-involved individuals. Services can be provided at court locations or other locations in the community under this option, such as critical access hospitals and primary care providers. Dr. Marley Doyle from Beacon is here to go into more depth about the needs identified throughout the working group sessions. And thank you, and I welcome your questions. And I hope I can answer them.
Are there any questions for Senator Sinner? Okay, thank you.
Thank you.
Good afternoon to the members of the Appropriations Committee. For the record, my name is Dr. Marley Doyle, Marleydoyle. I'm a psychiatrist and the director of the Behavioral Health Education Center of Nebraska, or Beacon. I am not appearing today on behalf of the University of Nebraska system, but as a private citizen in support of LB 1066, the proposal to appropriate funds to address the significant behavioral health workforce shortages in the state of Nebraska. We want to thank Senator Sinner for his work on the interim study LR 143, which led to this bill's introduction today. The COVID-19 pandemic has had a significant impact on people's mental health. According to a survey in October of 2021, nearly 34% of Nebraskans endorse anxiety or depressive symptoms. Drug overdose deaths are at an all-time high in Nebraska, and schools are reporting significant mental health issues among children and adolescents. There's a dire need for behavioral health professionals in our state if we want to adequately meet the needs of our citizens. For background, Beacon is the state-funded behavioral health workforce development center that is housed at the University of Nebraska Medical Center. Beacon's mission is to recruit, train, and retain the behavioral health workforce in order to improve access to behavioral health care for all Nebraskans. And we believe that this opportunity is unique in that we can really address this workforce shortage with an infusion to impact and increase the number of providers with one-time funding. LB 1066 is split up into 3 different categories. So the first is the internship program that Senator Stinner mentioned. With this funding, we would be able to provide additional training opportunities in the form of internships and practicums, specifically in rural Nebraska. From our work over the last decade, we know that students tend to practice where they train. And currently, the majority of the training opportunities in the state are in the Omaha and Lincoln area. So we think that if we are able to provide rural training opportunities, the likelihood that students will practice in those areas is much greater. The second area of funding would go to increase and develop a behavioral health network for telebehavioral health. And what this would do is increase the capacity for behavioral health services all across Nebraska. And this would include people that resided in nursing homes and in the most remote areas of the state. With a competitive application process, we would collaborate with stakeholders across the state to develop a telebehavioral health network to ensure access to telebehavioral health services for all regions of the state. The third area for the funding would go towards one-time training and educational opportunities to all sectors of the behavioral health workforce that were impacted by the COVID-19 pandemic. This would allow us to work with collaborators, providers, organizations to identify the areas of greatest need and develop training areas and workshops to address this need. We would also be able to provide training opportunities to students in behavioral health programs and provide education to them regarding the COVID-19 pandemic and its mental health impact. With these projects, we would be able to address the significant behavioral health shortage that we have in our state currently. And we think that with this one-time funding, we would be able to infuse a significant number of providers, which would ensure that we'd have a robust community of behavioral health providers even after the ARPA funding ends. We're grateful to Senator Stinner for his work and dedication to ensuring that all Nebraskans have access to behavioral health care. And I'm happy to answer any questions and grateful for the time.
Senator Dorn.
Thank you, Senator Hookerman. Thank you for being here.
Yeah.
You mentioned that we're having a critical shortage of, I guess, staff or whatever for this. Is that because of, I guess, not enough students entering this, or is it because of the other aspect where we've had such an increase in demand on our mental part?
Well, it's both actually. So we've always had a difficulty with behavioral health workforce shortage. That's nothing new. We don't have enough people, and that's particularly bad in rural areas. But with the pandemic, we've seen an increased demand for services. So it's just exacerbated the shortage that we already had. But one of the things that we do know too is that we would love more students to go into behavioral health careers. But currently we don't have enough training spots to keep all the students that we have. So we have far more applicants than we do spots. And so we're having to turn away some of our very own because we don't have enough training opportunities for them in our state. So this funding would allow us to create more training opportunities to be able to keep more students in the state of Nebraska.
Thank you.
Are there any other questions? Senator Coleman.
Thank you. Dr. Doyle, thanks for being here. I noticed on the handouts that you passed out that as a comparison, we're a little bit ahead of most other states around us in providing percentage of need that's being met.
In regards to like the 4-state region?
Yes.
Yep.
And I appreciate the fact that we're ahead of that game, but I'm also concerned that we need to stay ahead of this game. And so I appreciate what I'm hearing today. Have we done any work in the telehealth education arena in the past? And obviously we're doing something right, but there's a big need. So can you fill me in a little bit about where the telehealth education is working?
Yes, so the statistics that you're referring to are the HRSA data, which looks at the percentage of behavioral health providers that we have to meet the need. And Nebraska is at 48%. So that is not enough. Obviously, we want it to be 100%. That would mean we're fully meeting the need. But compared to the 4 states in our area, we're way ahead. And those states are actually looking at Beacon as a model to try to address their workforce shortages. So we're very proud of that fact. But as your question about telehealth, we have a telehealth training module that we update. It's on our website, and it's available freely for anybody. But we have an education partnership where all of our students are required to watch that before they graduate, so they at least have an idea of how to implement telehealth into their practice. So that is one thing that we're doing, and we're continuously updating it, trying to put more trainings out. 2 of the people that we have working with us at Beacon Panhandle are working on getting their certification in telehealth, and then that would allow them to be able to provide trainings and get more people certified. So it's a ripple effect, but that's where we're at right now.
And do people come to you through referrals from family practice doctors or specialists?
Well, we don't provide any direct behavioral health services.
You just do the education?
We do the training, yes. But we do get questions all the time about where can I go for training? How do I find out about this? We get requests to put on live trainings about telehealth. It's something that is of great interest. We just need more resources dedicated to it because it's not the answer, but it's part of it. And we need to be able to make sure that it's accessible to everyone in the state.
All right. Thank you very much. Thanks for being here.
Are there other questions? Thank you, Dr. Doyle.
Thank you.
Good afternoon, members of the Appropriations Committee. For the record, my name is Dr. Tom Magnuson. That's T-O-M-M-A-G-N-U-S-O-N. And I am a faculty psychiatrist at UNMC. Today, I am appearing, however, as a private citizen in support of LB 1066 and not on behalf of the University of Nebraska system. I've been practicing telepsychiatry across the state for nearly 20 years. And I'm going to focus my testimony on why using ARPA funds to invest in telebehavioral health services is critical for Nebraska. The quality of behavioral health care one receives should not be dictated by geography. In a state as vast as Nebraska, this unfortunately is still the case. However, my experience in providing telepsychiatry demonstrates there are ways to provide quality care even in remote regions, and that's through telebehavioral health services. As a board-certified geriatric psychiatrist, I currently provide telepsychiatry services to over 120 sites throughout Nebraska, including clinics, hospitals, nursing homes, assisted living facilities, and now, since the pandemic began, even in the homes of patients. The state is rapidly graying. However, there are only about 500 geriatric psychiatrists in the entire United States, let alone about 5 or 6 in Nebraska. Elderly citizens have the greatest need for psychiatric care, and telepsychiatry is a sustainable way to provide this needed level of quality psychiatric services to one of our most vulnerable populations. I found very few downsides to providing telepsychiatry. I can serve communities clearly I otherwise would not be able to. Also, we can maintain ongoing care as there's a much higher compliance rate with treatment because the barriers to getting to appointments have been removed. These barriers exist for patients living hours away from our clinic, as well as patients too frail to come to the clinic who could be living just blocks away. This is why ARPA funding supporting the development of a system of telebehavioral health providers is so important. If we as a state don't invest in this now, we will severely limit the quality of care for mentally ill residents living in Nebraska. This one-time ARPA investment will help build a network within the state that will ensure quality telebehavioral health for all, both now and in the future. Thank you for your time, and I'd be happy to answer any questions you may have.
Did you have a question?
Yeah.
Senator Dorn.
Thank you, Senator Dorn. Thank you for being here. When you're doing this, I call it the outstate telehealth. About how many patients are you seeing per day, or what's that like, I guess?
We probably see somewhere between 500 and 800 visits a year. So about half the time that I am in clinic at UNMC is seeing people throughout the state. So, I see nursing home patients in Mullen. Now, there are more people on my block than live in Mullen, So to be able to provide this level of care, again, it would be hard to get in to see somebody like me if you lived in Manhattan. So to be able to provide care to a place like that is pretty incredible. And the only way we can do that is through telehealth.
I call it the telehealth part. You're able to get connections, or most of those rural people are able to get to a spot where they can, when they have a meeting scheduled with you, they can get internet and such.
Yeah, and I think that there's also, concerns about, making sure that that's up to speed. I know there always are. But yeah, initially we did this through a T1. It was a closed circuit line, and it went through the state telehealth project years ago. And then what has happened with time is the technology has gotten so much better now. We're able to use encrypted software that really just goes out over the internet. So yeah, we can see, instead of having to make even somebody go 12 miles from the nursing home to the local hospital that had the equipment that the state had provided them, we can now just do it right in their facility. So, and the ability to go into somebody's house now, that's incredible.
Amazing. Thank you.
Yep.
Senator McDonald, do you have a question?
No, thank you. Thanks for being here, Senator Hilton. Thank you for asking.
Thank you. I thank you for being here, Dr. Max. And I, as having practiced healthcare for almost 40 years, I can't imagine a better specialty for telehealth than psychiatry. And to see where that could be expanded would be really a huge victory for our mental health. And so thank you for being here today, and thank you for what you do.
Thank you very much.
Good afternoon, Vice Chair Hilkeman, members of the Appropriations Committee. My name is Andy Hale, Andyhale, and I am Vice President of Advocacy for the Nebraska Hospital Association. I'm here representing the NHA and the Nebraska Chamber of Commerce, and I'm here to testify in support of LB 1066. Behavioral health disorders are a major public health issue, and hospitals provide essential behavioral health services to thousands of Nebraskans every day. Nearly 1 in 5 Nebraskans have a mental illness. 88 of Nebraska's 93 counties are designated as a federal mental health professional shortage area. 78 counties have no practicing psychiatrists. 32 counties lack a behavioral health provider of any kind. If you go 25 miles outside of Omaha and Lincoln, there is a 10,000 to 1 ratio of population and practicing psychiatrists. Compounding this problem is the high percentage of the behavioral health workforce is able to be expected to retire in the coming years. As the doctor before me, the psychiatrist, touched on telehealth. Telehealth provides the opportunity for alternative effective delivery of care and cost-saving opportunities for plans, providers, and beneficiaries. Considering the shortage of providers throughout the state, telehealth is even more important in ensuring timely and effective delivery of health services, particularly in rural areas, especially during the pandemic. According to CMS, the delivery of telehealth services for Medicaid and CHIP beneficiaries has risen over to 2,500% since the start of the pandemic. We are very excited to collaborate with Beacon so our hospitals can use this money in these grants, and we're excited to partner with them as they address these important issues. I want to thank Senator Stenner and his staff for introducing this important bill, and I ask you to support LB 1066.
Are there questions for Andy? Seeing none, thank you very much for being here today.
Thank you, Senator.
Good afternoon, Senator Hilkman and members of the Appropriations Committee. My name is Annette Dubas, ANNETTE DUBAS, and I'm the Executive Director for the Nebraska Association of Behavioral Health Organizations, otherwise known as NABHO. We represent 52 member organizations that include behavioral health providers, consumers, regional behavioral health authorities, and hospitals across our state. And our mission is to build alliances that ensure all Nebraskans have access to mental health and substance use disorder services. Today, we are here in strong support of LB 1066 and thank Senator Stinner for his steadfast support for behavioral health. This bill attempts to address many of the challenges faced by behavioral health and will improve access to care. And I could just basically say ditto to the previous testifiers because they really hit on all of the really key components. Workforce is front and center as our members focus on providing the right care at the right time. LB 1066 will provide the Behavioral Health Education Center with additional resources to step up their already successful efforts to support our existing workforce and expand opportunities to meet our current and future workforce needs, especially in the rural and frontier areas of our state. This legislation also invests in telehealth, which behavioral health has embraced with full measure. But telehealth also needs a comprehensive and geographically distributed workforce to really be effective and do all that it can really do. Addressing the provisional license issue is important as well. Provisional staff require a great deal of supervision to meet full licensure requirements. Fully licensed clinical staff provide this supervision. And while these staff members are providing supervision, they are not able to provide clinical services. And currently, there is no revenue support for supervisors or trainees while they're providing treatment. While 88 of Nebraska's 93 counties are still designated mental health profession shortage areas, and 23 counties have no behavioral health provider of any kind, with Beacon's efforts, we are tracking in the right direction. We still have a ways to go, but LB 1066 will help us focus our attention on strengthening and growing our workforce. The handouts that I've given you show the trends in workforce and an overview of our current workforce, and also a handout that shows the different licenses and the description of what each behavioral health license is able to do. Increasing access to acute care beds is also very important. All too often, individuals end up in emergency rooms or jail because there simply are not enough acute care beds that can safely and respectfully care for individuals experiencing mental health crises. Law enforcement in rural and frontier areas often have to drive for hours trying to find appropriate care for these individuals. These individuals are not criminals, but far too often, this is the only option available to them. Senator Stinner, NABHO sincerely thanks you for your steadfast support for those who provide and receive behavioral health care. You have stood strong for the most vulnerable populations, and we again thank you for your leadership and thank you for LB 1066. And I encourage the committee to support your efforts as well. And I'd be happy to answer any questions if I can.
Thank you. Does anyone have any questions for Mr. Voss? Welcome back, Senator. Comments? Thank you very much.
Thank you.
Next proponent.
Good afternoon, Senators. I appreciate this opportunity. My name is Dr. Sean Curtis, SHAWN-CURTIS. I'm from Lincoln, and I came before you as a licensed psychologist and a member of the Nebraska Psychological Association Legislative Committee in support of Senator Stinner's Bill LB 1066. I'm also honored to be employed as a neuropsychologist at Madonna Rehabilitation Hospital in Lincoln, but I'm not from here. I did not grow up in Nebraska. I have no family from here. And beyond my wife and son, I have no other family that lives here. I didn't even attend UNL here. So what did bring me to Nebraska in 2016, though, was to complete my rigorous and expensive journey to becoming a practicing psychologist with an opportunity to complete a clinical internship at an accredited program that offered specialized training in neurodevelopmental assessment. I found a diamond that was completely overlooked and not even considered by the vast majority of others seeking the same thing I was at the time. I mean, no disrespect, this is my home too, but what I found was that this was because it was Nebraska. It's a giant unknown for much of the rest of the country. And when viewed solely through the lens of prospective applicant, comparing it to other places, it offered less perks, less money, and had the appearance of less options. I applied and interviewed at 20 locations that literally crisscrossed the nation and competed with talented interns from all over on coveted spots in Arizona, New York, California, Texas, Kansas, and Florida. I could have literally gone anywhere, but I selected Nebraska because I took a chance on an interview that many overlooked and was blown away by the professionals I met and recognized the hidden opportunities that unless you applied and were granted an interview, would not have known existed. Opportunities that in many ways were unique and unlike anything I could have seen elsewhere. The Nebraska Internship Consortium of Professional Psychology is one of 3 accredited programs in the state. But just looking at the American Psychological Association website, a prospective applicant may easily overlook the variety and quality of training Nebraska has to offer, especially when factors like stipend, location, and benefits are also considered. This leads many to simply pass us by. While my placement was primarily in Beatrice, I also did a lot of work in Lincoln and had the opportunity to travel and help folks in rural communities who did not have routine access to services. In more than one case, I saw patients who had existing mental health diagnoses that were up to 20 years out of date, were misdiagnosed, or their course of illness had changed and had not been formally reassessed by a psychologist in all that time. This had a major impact on course of treatment and medication management by their primary care physician, who despite their own extensive training, typically do not have an equivalent level of education and clinical understanding specific to the nuance of complex psychological diagnosis. From my internship year and for the 3 years following me, I am the only one for my internship placement who stayed in Nebraska. I understand that this is not the experience of all internships in Nebraska. However, when asked, each of my colleagues cited income, more job opportunities, and a desire to live in an area with more stabilized funding for services. This bill would undoubtedly help to provide necessary funding to make us more competitive in not only attracting interns to come here, but incentivizing them to stay, and shows that Nebraska is proactive and serious about providing care for its citizens. What keeps me in Nebraska is the quality of life for my family and opportunity to work for a truly world-leading facility in neurorehabilitation, where I collaborate to treat traumatic brain injury, stroke, a wide array of complex and traumatic injury, and neurological diseases, including long-haul complications from COVID-19, which this bill also helps to address. But outside of the immediate region, no one knows what we have to offer here, and frankly, we need to expand and continue to build a strong mental health program that is supported by our legislature. My peers and former colleagues in Washington State think I'm crazy for wanting to stay here. And when we look across the nation at the opportunities that are afforded not only to someone like me with my education and experience, but also to those up and coming interns as well, it's easy to see why they might say that. Those same attractions to go other places are also pulling away our homegrown talent. The University of Nebraska is the only game in town for an APA accredited doctoral program. And while it offers an exceptional education, it is not enough to rely on the old axiom that if they're from here, they're going to stay here. Because if the opportunities are greater elsewhere, they will likely leave. Thank you so much for your time.
Anyone have any questions for Dr. Curtis?
Yeah.
Yes, Senator Dorn.
Thank you, Senator Hooperman. When some of your colleagues there that went other areas that cited a more stabilized funding for services, what exactly do you mean by that? I mean,
Sure.
The income here wasn't enough or what? Yeah.
It was a couple different reasons. The leading issue that I saw was my internship site was through the Department of Health and Human Services as part of the consortium. And at that time, our section was undergoing a lot of revision, and we lost a lot of funding for developmental disability, intellectual disability, neurodevelopmental cases. And quite honestly, there was concern that there weren't going to be jobs. So folks left.
Were they, some of them talking funding from, I call it the state of Nebraska then, or the legislature, or is it, or don't know?
That's a fantastic question, Senator. I'm not sure where the funding source changed, but it changed dramatically during my internship year.
Thank you.
Yeah.
Are there additional questions? Thank you for coming, Dr. Curtis.
Thank you so much.
Additional?
I'm sorry, there is a letter of support as well.
Okay, thank you. Are there additional proponents for 1066?
We skipped some. We did the first two and then we skipped down here. Yeah. Because you need to hear that.
Good afternoon, Vice Chair Hookman, members of the committee. For the record, my name is Corby Gilbertson. It's spelled Korby Gilbertson. I'm appearing today on behalf of myself in support of LB 1066. I know that's shocking, isn't it? I'm handing out a copy of a letter from Dr. Jones Hazeldine, who is from Rushville and had planned on being here today, and the weather kept her from traveling. So I told her that I would give all of you a copy of the letter. Dr. Jones Hazeldine was member of the working group that discussed this issue over the interim. And I want to back up a little bit and thank Senator Stenner for bringing everyone together. And I approached Senator Stenner last spring with the crazy idea that there had to be a way we could do something with behavioral health. And I knew that it was one of his passions, and it is for me as well in my private life. And I had done some research and found over 90 pages of existing statutes regarding behavioral health services for the state of Nebraska, and found that I don't think a lot of what was in the statute was actually taking place. We got together and he pulled together a group of amazing professionals, and all of them checked their allegiances at the door so that we could really get down to trying to find issues that were facing Nebraska, not just in rural areas, but across the state, because we talk a lot about the fact that we have issues out in rural Nebraska, but we have 3-month waiting periods for children to get care in Lincoln right now. So the need is everywhere, and is really something that needs to be addressed now. And the ARPA funds give us a one-time opportunity to do that. The biggest goal of why I went to Senator Stenner and talked to him was we needed to find a way to have a program that wouldn't create winners and losers, that didn't just benefit one provider. I did not tell any of my clients that have interest in this that I was even working on it. And you can imagine the few phone calls I got, and have maintained that after doing this for 30 years, I deserve to have one time where I work on something that I believe in and am not just up here carrying water for someone. But this plan, and if you look at all 3 pieces of legislation working in coordination with each other, is a way that we can really make a lasting impact on behavioral health in Nebraska. And by taking the money and putting it through Beacon, we are doing it in a fiscally responsible way. We are putting the money where they already have existing policies, procedures, and programs. We do not have to recreate the wheel. They have successful programs. They have increased access or increased the number of providers in the state by 38% in the last decade. As you heard earlier, that's better than any of our surrounding states. So it didn't make sense to send the money to HHS and say, hey, go create all of these new programs, because they would be behind by months, if not years, and just getting that done. Where this addresses the immediate needs and also provides a foundation for future. I wanted to talk about a couple other things that Senator Stenner mentioned in his opening. Number one, that's also can address some associated needs that were identified by the Criminal Justice Reinvestment Working Group. They identified 3 things regarding behavioral health. And I'll tell you that in their research, when they interviewed law enforcement's number one concern with criminal justice wasn't anything in the actual criminal justice process. It was the problem with behavioral health we have in this state. So there are 3 things, and we were not working together over the interim, but 3 things about incentivizing people to enter that workforce, provide proximate access to care through telehealth, providing services out either in courthouses or hospitals, primary care providers. And then 3rd, to educate those in the judicial and justice systems regarding brain development to help address the issue with children entering the pipeline to prison. And the only way we can stop that is by providing timely behavioral health care. So I will stop there and be happy to answer any questions if I can.
Thank you, Danny. Any questions you'd like at this point? Seeing none, thank you for your testimony.
Thank you.
Other proponents for 1066? Are there any opponents for 1066? Is there anyone that'd like to testify in the neutral position on 1066? Seeing none, Senator Sinner, you're welcome to close.
Thank you. Corby did a good job actually summing up a lot of the areas that I was going to talk about, but that's great. She did a whole lot better job than I did. But just to get on the record on a few things, I think on the acute bed issue, you saw 250,000. That is a quoted amount by the Hospital Association as it relates to funding an acute bed. Acute bed meaning somebody's having big time problems, comes in through the emergency ward. They need, care right away, and it's depending on how severe it is, which generally these are severe cases, they end up in what they call acute bed. So this provides 20 more. We got 16 at Regional West. They're 100% occupied. Unless they don't have the workforce to staff those beds. I talked to North Platte, the same issue. So these beds are full in rural Nebraska, not enough beds. Interestingly, that's the least profitable part of the hospital. So that's why it's in here. They do have to have somebody actually come in and I will tell you, probably my hospital in Western Nebraska will take up most of those. So there is a huge demand there. CJI was a new thing that kind of came out of those reports and we put it in here. That needs to be developed. Beacon, what a gem we found there. The work that they're doing right now. However, we had to expand what they're doing, and that means a statutorial change, and that's why it's over in HHS. So it's something I've pursued since I've been here. I think Senator Hilkeman, you came in with me, and it's been a concern. It's time. We've got 2 slots at our hospital for a psychiatrist that it's a revolving door. A lot of times they're vacant, can't find it. So the telehealth piece hopefully will provide some access to that. So with that, I'll conclude and ask if there's any questions.
Any additional questions of our chairman? Thank you, Senator Stinner. And I think you're next.
I am
That now closes. We do have, where's our little list here? We do have some, I will get that and we'll announce that the next, close the hearing on, here it is. At 1066, we have 15 letters of proponents, no opponents on that. And that will close the hearing on 1066. And we will now have the opening on 1089. Okay.
That's a the outside.
Senator, you may begin.
Good afternoon, members of the Appropriation Committee. For the record, my name is John, John Stinner, Stinnner, and I represent the 48th District, which is all of Scottsbluff, Banner, and Kimball counties. LB 1089 appropriates $60 million in ARPA funds to the Department of Health and Human Services to provide supplemental incentive payments for direct care staff employed at licensed and Medicaid certified nursing facilities. Under the bill, $45 million is divided proportionally by Medicaid certified beds. $15 million is divided equally among facilities with the top 25% of bed days paid by Medicaid in 2021, 2022. So we're kind of sorting out that the ones that need it the most, that have the most Medicaid beds days, are ones that are going to get a little bit more of the funding. The funds shall be used to provide supplemental incentive payments for direct care staff to enhance recruitment and retention. Intent language is also to include that supplemental payments be expended during 22-23, 23-24, and 24-25. Been brought to my attention that there are a few technical changes that will need to be made to LB 1089 to remain compliant with the coronavirus and local coronavirus state and local fiscal recovery funds program. The Treasury Department guidance on the use of these funds states that funds may not be used as a non-federal share for purpose of state Medicaid and CHIP programs. This would be a state-only program for payments to nursing facilities. Since it's assumed that the payments would be made in equal amounts over the 3-year fiscal period specified in the bill, there will be administrative costs to process the payments and monitor the use of funds in compliance with the provisions of ARPA. The estimated cost is $75,000, assuming the restrictions only applies to FMAT and not to the administrative match. The administrative cost will be paid 50% from general funds and 50% from federal. Since the program number identified in the bill is a state-only program, a new budget program number will be needed to separate these funds from Medicaid funds. To prevent unintended impacts on Medicaid payments, the term supplemental incentive payment needs to be changed to provider relief program. I am happy to work with the committee to assess some of these needed changes. Thank you, and I will welcome any questions, and I will tell you that HHS came to me and actually gave me these changes, so they have looked at this. These are needed changes in order to make sure it's in compliance and we don't stub our toe with CMS and some of their language. So it's technical in nature, and obviously you're going to have administrative costs associated with that. That's the $75,000. So with that, I'll take any questions.
Senator Clements.
Thank you, Senator Huffman. Thank you, Senator Stinner. This payment to the 25% of top bed days, is that the number of beds, or is it the percentage of Medicaid beds you had in a facility?
It is the percentage, well, the percentage of Medicaid beds is the way I would like to see it done. Now, if it reads a little bit different than that, then I'm going to have to probably change it. But that's my understanding, is somebody that had 80% Medicaid, they really need a little extra lift.
Yeah, I'm hoping that that's what you mean by this.
That was the intent of it anyway.
Thank you.
I hope it reads that way.
Let's see.
Are there additional questions? Okay. Thank you, Senator Stinner. Our first proponent for 1089.
Good afternoon, Senator Helkerman, members of the Appropriations Committee. My name is Jaylene Carpenter, Jalenecarpenter, and I'm the President and CEO of Nebraska Healthcare Association. On behalf of our 190 nonprofit proprietary nursing facility members, I'm here to testify in support of LB 1089 to appropriate $60 million in a one-time funding from the American Rescue Plan Act for the recruitment and retention pay for nursing facility staff. Would like to thank Senator Stinner for his steadfast support of long-term care providers and the Nebraskans that they serve. The COVID-19 pandemic continues to have an incredible impact on our state's skilled nursing facilities who care for our most vulnerable populations. During the pandemic, nursing facilities have experienced significant cost increases, with their greatest being the cost of workforce and wage inflation. Team members working on the front lines in Nebraska nursing facilities are healthcare heroes. Even as the pandemic approaches the 2-year mark, these direct care team members continue to address facility outbreaks, putting themselves and their families at risk to care for Nebraska's elderly. To remain competitive in the workforce marketplace, these facilities must continue to offer hero pay in order to recruit and retain dedicated team members who will again continue to care for Nebraskans during this difficult time. As stated earlier, in the last month, more long-term care facilities have experienced COVID-19 outbreaks more than at any time in the pandemic. And all through this time, their costs continue to rise. These one-time American Rescue Plan Act funds will be used to pay recruitment and retention bonuses for direct care team members. This includes all team members: housekeeping, laundry, dietary, CNAs, medication aides, nurses, all of those who provide direct care for our residents. $45 million of this 3-year funding be awarded proportionately to all Medicare and Medicaid nursing facilities, and the remaining $15 million would be directed to those facilities caring for the highest percentage of Medicaid residents. Following me, you will hear from providers who have experienced this firsthand. I'd like to also note that Nebraska Chamber has come in as support of this bill as well. Again, we thank Senator Stinner and his continued dedication for this issue. I appreciate your time and happy to answer any questions.
Any questions of Mrs. Carpenter? Seeing none, thank you for being here today.
Good afternoon, members of the Appropriations Committee. My name is Carrie Walkenfuss, K-A-R-I-W-O-C-K-E-N-F-U-S-S, and I am the administrator of the Louisville Care Center and also chair of the Nebraska Nursing Facility Association. And I am here to support our LB 1089. 1089 appropriates the ARPA funds to Nebraska's nursing facility providers to help provide recruitment and retention incentives for current and future team members. Louisville Care Center is a 61-bed skilled nursing facility with an attached 26-bed assisted living facility. We are a not-for-profit government city-owned facility, and we are located in Louisville, which is only 15 miles south of Omaha. One would think that being only 15 miles from Omaha, that it would be easier to recruit quality nursing staff. However, it is quite the opposite. We have been advertising for a full year for a night nurse, which ours retired in September after 28 years of service. And we've also been advertising weekly for the last 2 years for full-time, part-time LPN RNs, and for all shifts, and also certified nurse aides and medication aides. We only have 3 of our own professional nurses at this time on staff, and they are working double shifts and overtime to meet the staffing needs that we have. Unfortunately, we've lost 6 nurses in the last year who have went to hospitals and also to other staffing agencies where they were able to get more pay and also generous hire-on bonuses. To assist in meeting our staffing needs, we've had no choice but to hire traveling or agency nursing. But that costs us double or sometimes triple the cost to cover our needs. Last year, our little facility spent almost $600,000 on agency and staffing nursing. And they do not do the same investment in caring for our elders as our facility team members. Agency and traveling staff are challenging in many ways to work with. They are allowed to pick and choose their schedules, resulting in many agency staff electing not to work weekends or holidays. The cost to fill these positions for our facility is making a catastrophic impact. Financially, we are at the mercy of staffing and traveling agencies, resulting in a monthly deficit on the overhaul operations of our facility. If ARPA funds were granted, we would utilize the funds for recruitment and retention for staff in the following ways. First, we would do pickup bonuses, which we could pay staff extra money to pick up additional shifts. Retention bonuses, which would pay according to the years that they have served us, and hire-on bonuses to help recruit potential staff. We could also pay for certified nurse aide classes, and we could offer scholarships for RN and LPN students that love long-term care. And we could also pay for our professional nurses' CEUs and also maybe possibly their license for every 2 years. We are not supplemented by any form from the city of Louisville. The funding from LB 1089 is necessary for the direct care staff needed to provide care for the most vulnerable Nebraskans who will care for the elderly if we cannot. I would like to thank you for your time and your consideration for 1089. Can I answer any questions?
Senator Dorn.
Thank you, Chair. Senator Hickman, thank you for being here. This says 4 Medicaid nursing homes. Are all of the nursing homes in the state Medicaid, or are there some that are not?
I think that there's some that are not, but I would have to ask Nebraska Healthcare for sure. We run about anywhere from 65 to 75% Medicaid on a normal basis.
Additional questions?
Yes,
Yes, Senator Clements.
thank you, Carrie. Appreciate the work you do for my district. And I was going to also ask about the Medicaid percentage. Has that increased over the last couple of years?
We are about the same. We're running about the same as what we were 2 years ago.
And with COVID, have you had more empty beds than you had before?
Yes, we are probably at the lowest census today than we have had ever in the history of Louisville.
That's also a factor.
Yep.
That if you fill more beds, are you able to staff for them?
We would have to, but yeah, right now we could probably bring on, probably depending upon care level, some more residents with the staffing that we're running.
All right, thank you.
Any additional questions? I have a question. I just thinking about it here. If when we bring these on, we're bringing it on for all the care centers to be able to take advantage of that.
Right.
How is that going to help you at Louisville when you have everybody else having the exact same? Do you think we're going to bring different people into the pool?
I do.
Or are we just going to have a transfer?
No, I think that would bring other people that would like to come to long-term care instead of maybe the hospital. Some of my nurses, they didn't want to leave, but the money was there. They love long-term care. It could bring some of those people back to us.
And you said 75% Medicaid at your center. Okay. Any additional questions? Thank you much for being here.
Thank you for your time.
Good afternoon, Chairperson Stetter, Hinkleman, and members of the Appropriations Committee. My name is Lois Jordan, Loisjordan. I'm a registered nurse and president and CEO of Midwest Geriatrics, which operates Florence Home Healthcare Center, Royal Oaks Assisted Living, House of Hope Assisted Living, and Memory Care in Omaha. We are a member of Leading Age Nebraska, and I serve on the Leading Age Nebraska Executive Committee. Thank you for the opportunity to test on behalf of LB 1089. Testify. Florence Home Healthcare Center is a mission-driven organization that provides skilled nursing services for 95 to 100 seniors in Nebraska, and more than 85% of those individuals are eligible for Medicaid. We are one of the Nebraska facilities in the top 25% of bed days paid by Medicaid. In the past 2 years, we have seen unprecedented staffing shortages in long-term care. Our turnover rate among direct care staff is on average 48% a year. We currently have 83 employees that are employed in a direct care capacity at Florence Home Healthcare Center, our nursing home. In addition to the employees of Florence Home, we're averaging 53 temporary workers to fill those open positions, and that's per week. The cost of these temporary workers is substantially higher for our facility than what we're paying our own employees, which leads to significant morale problems, continuity of care issues, and certainly financial strain. As we incur the high cost of temporary staffing, there's little left at the end of the day to provide additional, yet much deserved compensation to our existing employees. The funds provided under this bill would allow us to provide additional compensation through recruitment and retention incentives for our staff that have been faithfully dedicated to serving our residents. Having our own direct caregivers on a consistent basis enhances the quality of care our residents receive. Our residents want and need consistent caregivers to depend on. We want to be able to recognize the outstanding work that's being done by our employees who have continued to provide care throughout this pandemic. Funding through LB 1089 for direct caregivers will be sincerely appreciated by these hardworking individuals. I'll answer any questions.
Are there questions for Ms. Jordan? It's always seemed to me like when you pay a large premium for the traveling nurses that are there. Why do we not increase the rate of pay to your full-time staff at a level that you can retain them rather than having to pay this much higher fee for the traveling staff?
Anytime any facility one has to use temporary staffing, it's at the hope that it's very short-term, because the rates that we have to pay for that temporary staff is not sustainable. We aren't reimbursed to be able to pay those rates long-term. And so it is our hope that it's only for a short period. Now factoring in second year of COVID and no end in sight to fill these openings, that temporary use of temporary staffing isn't so temporary anymore.
Is it the new norm?
If it is, then there will be much fewer nursing homes in business because we can't afford to continue to pay those rates unless reimbursement changes. So I hope I recognize, and as a registered nurse, I too believe that I'd love to be able to compensate our staff at that rate. I really would. They work very, very hard. They've earned it. But we simply don't have a way to pay that continuously like this. And when we don't have the staff to be able to provide the care, we can't admit residents. If we don't admit, we don't have an income. And so it just perpetuates the issue and the problem. So.
And what percentage of your patients are Medicaid?
80 to 85% of our folks are Medicaid.
Okay. Thank you. Any additional questions? Thank you for being here. The next proponent. Seeing none, are there any opponents for number 1089? Is there anyone that would like to testify in the neutral capacity on LB 1089? Seeing none, Chairman Stinner, waives closing. We have 26 letters of support for 1089. There's one letter in opposition. And with that, this will close the hearing on LB 1089. And we will begin the hearing on LB 1269.
Next one.
I don't think 1269 is the next one.
Almost at the back.
They switched the schedule.
Just a second here, I'm confused. What are we doing? What are we doing? This says 1269. We got 1269?
Are you LB's 1269?
Yeah.
That's what we're doing.
All right. Senator, sorry, I was just,
No problem.
needed clarification. Thank you.
Good afternoon, Chairman Stenner and members of the Appropriations Committee. For the record, my name is Dave Merman. That's spelled D-A-V-E-M-U-R-M-A-N. And I represent the counties of Clay, Nuckolls, Webster, Franklin, Harlan, Furnace, Red Willow, and part of Phelps County. And I'm here today to introduce LB 1269. The intent of this bill is to appropriate $10 million to the Department of Health and Human Services from funds allocated pursuant to the American Rescue Plan Act for fiscal year 22-23 for the repayment of qualified educational debts owed by eligible health professionals under the Rural Health Systems and Professional Incentive Act. This is not a new program or ask. Rather, it is an effective existing program that can easily be bolstered by ARPA funds. The act contains the governing statutes for the Rural Health Professional Student Loan Repayment Program housed at DHHS. Basically, the program provides funds for student loan repayment to health professionals who go and practice in rural health shortage areas. There is a practice commitment of 3 or 4 years for these professionals. If they break this commitment, they are required to pay back the funds they borrowed. The program is open to physicians, physician's assistants, nurse practitioners, dentists, pharmacists, occupational therapists, physical therapists, psychologists, and other mental health professionals and has been very successful in meeting rural health care needs. The last several years, there has been a wait list for this program, which means we weren't fully maximizing our options to send more health professionals to rural areas to address the access issues, even though the demand was there. The legislature increased the funding to the program in last year's budget, but those funds are dwindling quickly through current program participation. Thus, this request is appropriate from what could reasonably be obligated and spent under this program by the 2026 deadline. This session, I introduced a companion bill, LB 1007, to further maximize this important program by making it clear in statute that if federal law does not require a local match requirement, that the state also not require a local match. This bill was recently heard in the HHS committee. Currently, the program requires a local match as a way for local communities to have a skin in the game in partnership with the state. The ability of local clinic or community to produce enough local matching funds is often the biggest hindrance to increasing available health professional positions that qualify for the program. However, due to the pandemic, the Federal Health Resources Services Administration will be sending funds to the state for this program that waives the local match requirement. Pair these funds with ARPA funds, which also do not require a local match, and we have the opportunity to vastly increase the number of health professionals serving in rural shortage areas. This represents a one-time opportunity to bolster a critical need in rural Nebraska. When the federal funds are exhausted, the program will revert back to requiring a local match commitment from the locality, meaning the state does not bear an increased ongoing cost for this program. Currently, it is my understanding that there are approximately 200 providers in the program now. This funding would accommodate approximately 1,000 providers, making a huge immediate impact in rural health care now. A sector which was greatly impacted by the pandemic and one that our constituents and fellow Nebraskans must rely on to live their lives. I am hoping this is something the committee can get done this year so that we may take full advantage of these federal funds. Chair Stenner and committee members, thank you for your consideration of LB 1269. I'd be happy to take any questions, but there's others behind you who can maybe answer.
Senator Dorn.
Well, I might wait and ask then, because my question is the 200 that are in that now, that program, and this is going to fund up to 1,000. So it's because of your bill that would not require the local match, then that would expand the program.
Yes, I think so, but maybe some others can clarify better.
Any additional questions, Senator Erdman?
Thank you, Senator. Thank you, Senator Merman. How many dollars are in this program now? What did we appropriate last year? Do you know?
I don't know what it was last year. Probably somebody behind me.
All right, thank you.
Clarify.
Any additional questions? Seeing none, thank you. Opponents, yes, please.
Thank you, Senator Stinner, members of the Appropriations Committee. My name is Dr. Dave Watts. I'm a retired physician from Omaha and current president of the Nebraska Medical Association. I'm here today to testify in support of LB 1269, and the NMA thanks Senator Merman for working with us to introduce this legislation. As you heard from Senator Merman,
Could you spell your name?
oh, I'm so sorry. Thank you. Davewatts. As you heard from Senator Merman, the Rural Health Professional Student Loan Repayment Program is a popular program that allows Nebraska to bridge access gaps to healthcare in our rural areas. It's so popular that it had a wait list of health professionals looking to participate the last several years. The NMA thanks this committee for appropriating enough funds in last year's budget to address the wait list. The program is not only popular, it's effective. According to a DHHS and University of Nebraska study, approximately 4 of 10 health providers in small towns and rural areas in Nebraska have participated in the student loan repayment programs. Furthermore, providers participating in these programs have a longer retention time in rural areas than providers who do not participate. And participating providers also leave rural areas at a rate 43% lower than providers who do not participate. In addition, the study estimates that this program has yielded over 2,500 years of total experience for health professionals in rural areas, which averages out to just under 9.5 years per participant and is over 3 times longer than the minimum practice obligation. This has resulted in an estimated economic impact to the state of $2.7 billion over the lifetime of this program, according to this study. Thus, the data is clear. The Rural Health Professional Student Loan Repayment Program works at addressing provider shortages in rural Nebraska while boosting the health and livelihoods of our rural population. In anticipation of federal funds coming to the state, the NMA and other healthcare partners began looking at how best to utilize these funds to expand the number of health professionals practicing in rural areas. Increasing the funding for this program with ARPA funds made great sense to us, given its high usage rate and effectiveness at retaining professionals in rural areas. Given the limited window we have to make an impact on access to rural health care with minimal cost to the state, the NMA respectfully urges full support from the committee for the ARPA funding request found in LB 1269. Thank you for your time.
Thank you. Questions? Seeing none, thank you.
Good afternoon, Senator Stinner, members of the Appropriations Committee. My name is Andy Hale, A-N-D-Y-H-A-L-E, and I am Vice President of Advocacy for the Nebraska Hospital Association. I'm here representing the NHA and the Nebraska Chamber of Commerce, and I'm here to support LB 1269. There's a healthcare workforce shortage in Nebraska. It affects both Nebraska's physical health and its economic health. The lack of care impedes the ability of communities throughout the state to draw and hold residents and the businesses that employ them. This issue has only become more serious during the pandemic. There are substantial gaps in the distribution of healthcare professionals across Nebraska. 66 of Nebraska counties have been deemed medically underserved. Our hospitals struggle at attracting and retaining physicians, nurses, and other healthcare professionals. 13 of Nebraska's 93 counties have no primary care physician. 44 counties do not have any OB/GYN physicians. 78 counties have no practicing psychiatrists. And nearly 1/5 of the physicians in Nebraska are more than 60 years old. Not only is this great for our hospitals and healthcare facilities, but also provides a boost in rural communities when we can get these individuals to stay. One primary care physician in a rural community creates 23 jobs annually. 14% of the total employment in rural communities is attributed to the health sector. Dr. Watts mentioned, as well as Senator Merman, the success rate of this program, and they put out an annual report every year, and this has over a 93% success rate. And this program has been instrumental in recruiting and retention healthcare providers to our rural communities. I want to thank Senator Merman and his staff for introducing this bill. I'd ask that you would advance LB 1269. One last thing before I open up for questions. I just read this morning Becker's Hospital Review, talked about the healthcare workers, and they had a survey that showed 23% of healthcare workers are likely to leave the field. So this is a problem. We knew this was a problem before, and unfortunately, it's only gotten worse. So I'll take any questions, Senator.
Any questions? Seeing none, thank you.
Thank you, Senator Stinner. Senators.
Any additional proponents? Any opponents? Anyone in the neutral capacity? Senator, would you like to close?
Thank you all for the consideration of this bill. Access to rural health care has been a significant problem for many years. The COVID-19 pandemic has magnified this issue. LB 1269 represents a unique one-time opportunity to make a big difference by providing federal funds for student loan repayments of doctors, nurses, dentists, pharmacists, physicians, physical therapists, mental health practitioners, and other health professionals who commit to and actually practice 3 or 4 years in a rural shortage area. And I ask that you support this bill and give it timely consideration and move it forward out of committee. In answering Senator Erdman's question, last year the legislature appointed or appropriated last biennium $3 million for this program. And this increased funding will greatly increase the number participating. As I said in my opening, from 200 providers to approximately 1,000 additional providers.
Very good. Any questions? Seeing none, thank you, Senator. We have 5 letters of support for LB 1269, and that concludes our hearing on 1269. I hope we'll now open with LB 1172. Nope.
Through 1183.
783.
Maybe I should get to the right.
1183.
1183, excuse me. I was looking at this other page as proponents.
We changed the lineup.
Which one we at? 1183? Go ahead.
Good afternoon, Senator Stenner, Chairman Stenner, members of the committee. My name is Senator Ray Aguilar, spelled R-A-Y-A-G-U-I-L-A-R. I represent Legislative District 35, which includes Grand Island. Love your ties. I'm here today to introduce 1183. The COVID-19 pandemic has shown us all the fragile nature of our health system. No other healthcare facility has seen that more directly than those who serve our most vulnerable Nebraskans, the federally qualified health centers, RFQHCs. We use the phrase safety net all the time, but our 7 health centers located in Gering, Grand Island, Columbus, Norfolk, Lincoln, and 2 in Omaha have been the safety net on the front lines of this crisis, serving our neighbors and their families who do not have access to health care because of financial, racial, ethnic, or geographic barriers. These health centers are funded with federal and some state dollars, some insurance, and through patients paying on a sliding fee scale. They provide high-quality primary care, preventative care, including medical, dental, behavioral health, and pharmacy services. They are where families have sought care for the effects of COVID-19 and its variants, received tests, PPE, and vaccines. Several of you on this committee have championed their work in the past and know how important they are to our communities they serve. I too am aware of the impact of the Heartland Health Center has made for my neighbors and our community in Grand Island. I can't think of a better way to spend $25 million, a small fraction of overall relief dollars coming to Nebraska, than supporting these centers and funding grants for one-time shovel-ready capital construction projects with dollars committed by December 31st of 2024 and expended by December 31st, 2026. I can't think of any other proposals that serves more of our citizens that have felt the most negative economic impact by this pandemic. By building or improving buildings to expand access to these healthcare centers, we can allow them to serve smaller communities in rural areas so that citizens do not have to travel long distance to access health care. Today, you will hear details on their shovel-ready projects that will continue their essential work. It is likely we will be dealing with another healthcare crisis in the near future. And by making this decision today, we can grow and strengthen our healthcare system for all Nebraskans to mitigate that impact. Thank you for all the hard work you do on this committee and for considering this important legislation. I'll take any questions.
Questions? Seeing none, thank you.
Thank you, sir.
Good things come to those who wait. Chairperson Stenner, members of the Appropriations Committee, my name is Kenny, Kenny, McMorris, MCMORRIS, and I have the pleasure of serving as the Chief Executive Officer for Charles Drew Health Center, located in North Omaha. I'm also here representing the Health Center Association of Nebraska and our 7 federally qualified health centers in our state. LB 1183 directs $25 million in ARPA funding to be used for capital construction projects for federally qualified health centers. FQHCs are nonprofit, community-led organizations that receive federal funding to provide primary care services in medically underserved areas. We offer comprehensive primary medical, dental, behavioral health, including substance use supports, and pharmacy services for all people, regardless of their insurance status or ability to pay. Health centers have been on the front lines of the COVID-19 pandemic. The 7 FQHCs in Nebraska have provided over 64,000 COVID-19 tests and have vaccinated over 42,000 individuals. Health centers are a critical component of the healthcare safety net. We served over 107,000 patients in 2020 alone, 95% of whom were low income, and 2/3 were people of color. In addition, over 30% of uninsured Nebraskans receive care at a federally qualified health center, as well as 12% of Medicaid beneficiaries. Simply put, this ARPA funding would provide health centers in Nebraska the funds needed to build and expand current sites and serve more patients in our respective communities. We estimate that with this funding, health centers across Nebraska would be able to build enough space to see over 30,000 patients, roughly 2/3 of whom would be new patients, and 1/3 would be existing patients accessing new services like dental and behavioral health. This will be enough space to house approximately 61 new providers, such as doctors, dentists, and mental health professionals. My colleagues will soon testify on how the money will support them in expanding access in rural areas. I have also included a map of expansion opportunities across the state with my testimony. At Charles Drew Health Center, located in the heart of North Omaha, this money would allow us to expand efforts to build out additional space in addressing behavioral health, including access to substance use support, advance continuity of care through medical respite for those experiencing homelessness, and expand access to coordinated primary care for youth and adults who have been system impacted, while training a more competitive and nimble healthcare workforce to address the complexities within the healthcare delivery system that have contributed to ongoing modern-day health disparities. It is appropriate and indeed the intent of the funding that ARPA money goes towards providing healthcare to communities hit the hardest by the pandemic. However, this is also a good economic investment. Based upon estimates we have provided to the committee, this new construction will have one-time impact of $60 million on the local economies across the state, with an estimated 504 jobs related to this construction. However, the ongoing benefits are even more significant. The expanded clinic space will create over 40 million of new economic impact annually, as well as over 400 good jobs. These will be busy primary care clinics, staffed with nurses, doctors, dentists, behavioral health professionals, and providers and support staff who will bring needed health care into the community, but also jobs and spending. We recognize that you all have a very daunting task in front of you, and we'll hear a lot of stories and good causes for the use of funds. But we know that the work that we do every day is transformational, and our state will have a long-term economic impact. And we also want to thank Senator Aguilar for the support, and we ask that you advance LB 1183 to move forward. I'll take any questions.
Senator Dorn.
Thank you, Chairman Senator. Thank you for being here. Could you explain a little bit how one becomes federally qualified health center versus, I call it just a hospital.
Yeah. So the federally qualified health center, or community health center movement actually started in the 1960s. It's a federal program and one in which that provides integrated primary care in rural and urban areas. And so one of the things in our state, we have 7. We actually occupy about 72 locations across the state, but you have to go through a level of rigorous assessment, things with the federal government to meet certain requirements. And as part of that, then you adhere to a level of standard of care that you're going, in terms of being able to get these additional resources from the federal government and benefit the federal government, that you make sure that you're providing care to everyone in the community, regardless of their insurance status or ability to pay. And so within our state, we look at opportunities, not to say that anyone can't become an FQHC, but we feel really good about the 7 that we have. And this will provide an opportunity to really expand access. Our health centers have had a rich history and a rich record of being able to provide these services. And mine specifically is the oldest FQHC in the state. Interesting enough, my family was one of the first families to get services at Charles Juhl Health Center. And so when you kind of look at this and the work that we're doing and the lives that we're impacting, can't think of a better way to use ARPA funding and ongoing support.
So is the main criteria, I guess, that the fact that you now have to serve everybody, or is it the fact that you qualify for more of a higher rate of federal funding, or don't you?
There's no change in the qualification of federal funding, but part of it is that we're going to continue to keep serving more regardless of the funding that we get. And so when we look at opportunities like this, philanthropy has been great for us in many cases. We've also been able to get some significant support from the federal government as well, but it doesn't go as far as we really can have it go as it relates to our patients. And so this will give us an opportunity to have some bricks and mortar, build additional locations that allows us to be able to do more and have a greater return on investment.
Another place you may want to look is this DED has about $126 million for capital. That's hospitals and the like of that. I would pursue that avenue as well. So anyhow, additional questions?
Yeah, so these funds would all be used for capital improvements.
Yeah, so each health center has kind of shovel-ready projects that we've been sitting on for a little while now. And so this opportunity will give us a chance to really take those projects and be able to start expanding for services for our patients.
And how will you determine how the money is distributed?
Yeah, so we'll look at between the 7 health centers, typically the funds that we have, we've historically have looked at how many patients we serve by our previous calendar year. There's a piece called the Uniform Data Set that every health center across the country has to report out to the federal government. And so based on the number of patients that we typically serve, uninsured patients and the liking, we typically would distribute the funds equally amongst the 7 health centers as it relates to that.
We've been hearing all afternoon about the difficulty in getting healthcare staff. Are you not having that difficulty?
No, sir. Yes, we're feeling it just like everyone else. And so I think that with our model of care, we really rely upon our care teams and support staff to really go a long way for our patients. Additionally, we've heard a lot today about telehealth and telemedicine, and we leverage those means as well. Many of our patients speak English as a second language, so community health workers and individuals that help get out into the community and making sure that we build those relationships with our clientele. A lot of our patients just have challenges with navigating the healthcare delivery system. So yes, we are feeling the pinch with providers and nursing staff and support staff, but we've made a history on making a difference with the resources that we have.
So, but if I hear this right, for you, it's more important to build more structure than it is to compensate or bonus your healthcare staff?
Now, I'm not saying it's more important. We're just prioritizing this for right now, but it is important that we're compensating our staff and remaining competitive. But we also recognize that we're going to have to be looking towards the future. And when you look at the dollars and the opportunity here with ARPA, and we know, at least at this point, there's going to be some long-term ramifications associated with COVID-19 and being able to get access to primary care. So we're trying to position ourselves to be ready to take in the new wave and make sure that everyone in our community has a healthcare home.
Additional questions? Seeing none, thank you very much.
All right, thank you. Additionally, we had a consumer board member as well that unfortunately had to leave, so his testimony is also included here too.
Thank you. Afternoon.
Good afternoon, Chairman Stinner and members of the Appropriations Committee. I am Kathy Nordby, K-A-T-H-Y. Nordby is N-O-R-D-B-Y, and I am the CEO of Midtown Health Center in Norfolk. I'm here today to testify in support of LB 1183 and really thank Senator Aguilar for recognizing our needs and responding to that. So thank you for that. Midtown Health Center itself served, in my document, it shows 7,000 patients. That was 2020. We actually increased by 21%, nearly brushing up against 8,000 patients in the last year. So we've increased by that 21%. About 50% of our patients are racial and ethnic minorities, and nearly 90% of them earn under 200% of poverty as a family. So that's about what, 54,000 for a family of 4. Nearly 1 out of every 5 of our patients is best served in a language other than English. So we have a lot of barriers to care that we struggle with. I have testimony. I'm going to leave that stand as it is, but I'm going to go a little bit off kilter because I get all excited by hearing the questions and some of the comments and the testimony before. I was assigned to focus on our behavioral health services because we've really addressed some local needs in rural Nebraska. But I'm also going to touch on the educational capacity, and I think FQHCs serve ready to give statewide educational opportunities. And I've worked with our state association, I've worked with local partners, I'm working with Senator Flood right now trying to bring up UNMC, Wayne State College, Northeast Community College to address our spectrum and offer training facilities. But when you need a training facility, you also need space. Because if you have a nurse doing a round in her training, she needs a spot next to the nurse that's already sitting at capacity. And when you grow by 21%, I was at capacity before COVID hit. I took a 3% drop the year that COVID was at its worst, mostly because I had to shut down my dental unit, my behavioral health, my schools closed. So I dipped a little bit and I was on the precipice of really growing, and that happened in 2021, that we really are experiencing a very significant shortage. Some of the federal COVID funds came to me and I have a portion of my expansion covered, but even my local site, my facility, I kicked myself out to go rent space because my providers needed my office. And every office I build is 10 by 11 so I can plumb it and make it a medical room. And that's what I have worked on in the past, but I'm at capacity at my local site and I'm working hard to find ways to support that. When we talk about behavioral health services, when I was supposed to focus on that, when we first opened in the community of Madison, in a rural community, there's a real stigmatization about access to behavioral health services. And I think telehealth is a wonderful solution. But what we found is even when we referred internally from our doctor to our behaviorist, we had a 50% no-show rate. And we've done things now to go, what the heck? And we found that through a warm handoff, that if they meet the behaviorist or meet a case manager that assures that they show up at their behavioral health appointment, we make it better. Our biggest feature is that we started offering services at schools, both Madison schools and Norfolk Public Schools. I provide K-12 in Madison, and I provide K-5 or 5th grade in the Norfolk Public Schools because they have other contracts with other providers to do the higher grades. But what we found is you don't have a no-show rate because the teachers are so excited that they're getting access to this care. The kids show up, they're seen, but the parents don't have to lose their income. And the people that struggle with mental health issues are twice as likely if you also are impoverished. So the poor, our featured patient care has doubled the medical health need or behavioral health needs than the average population. So we're the right place to try to expand behavioral health. But because of the stigmatization, I find it's better that if I have a facility, I'm going all off script, but if you have a facility, like if I placed one in Wakefield and I start seeing primary care, you're coming to see the doctor, that eventually you can give them that telehealth to the behaviorist or that warm handoff, or the school, the one we have in the school is coming from 3 to 5 at my office. Those are all access points where I can support them. And through partnerships like One World, I have access to a bilingual psychiatrist. I would never have that in my lifetime if it weren't for my partnership with One World out of Omaha, South Omaha. So those are points of contact where I can access specialty and still support at the primary care level when we're experiencing the shortages. And I stand ready to partner with educational institutions to provide the training locally. Because once we send them to Omaha and Lincoln, we get about, 1/5 of them back. So we want to keep them home and train them well. So I think we're the best place for this. And I just estimated my testimony, but I would welcome any questions.
Thank you. Questions? Seeing none, thank you.
Thank you for your time.
Afternoon.
Good afternoon. Can I get these old specs on for the? Good afternoon, Chairman Stinner and members of Appropriation Committee. My name is Tammy Smith, TAMI-SMITH. I am the CEO at Heartland Health Center in Grand Island. I am here today to testify in support of LB 1183. And I would really like to thank Senator Aguilar for introducing this important legislation. Heartland Health Center opened its doors in 2014. In that first year, we served 841 patients. Last year, we served 6,695 patients, which is a 700% increase over the last 7 years. Since we opened, we have expanded services to include pediatrics, dental, behavioral health, telehealth, and behavioral health services in Grand Island Public Schools. In 2020, we had the opportunity during the pandemic to open a satellite clinic in Ravenna. Their local private clinic closed, and we were contacted by UNMC to see if we would be willing to partner. And we were able to bring medical and behavioral health services directly to the community in several smaller neighboring communities, which has been a huge success. And I'll get off a script a little bit as well. As Kathy talked about the behavioral health and the stigma, I was very fearful of taking it into a small town like Ravenna and the possibility of people not being willing to receive behavioral health services. Much to my surprise, that has not been the case. We have been able to grow the behavioral health and help the Ravenna Public Schools as well as community members with their behavioral health needs that I think have been even more highly affected with the pandemic. As a rural health provider, I do see firsthand the impact that we have on our patients and the community through accessible and comprehensive care. Outside of Omaha and Lincoln, the greatest number of low-income Nebraskans who are currently not served by a health center live in Grand Island, Hastings, and North Platte. Heartland Health Center serves patients from all those communities. And that's right, people come to Heartland all the way from North Platte to receive health care at the clinic. Can you imagine how difficult it is for a patient to keep their diabetes under control when they have to make a 4-hour trip just to attend a medical appointment? The American Rescue Plan Act offers Nebraska a once-in-a-lifetime opportunity to address the healthcare barriers that have plagued rural Nebraska for decades. This limited access has led to worse health indicators and a higher likelihood that people will forego healthcare altogether. This is especially true for low-income and marginalized populations. In Grand Island, we are putting the finishing touches on a new clinic location that will triple the size of our space and allow us to serve more patients in that community. We currently cannot bring on new providers or new patients because we simply do not have the space in our current facility. And while this new location will address our needs in Grand Island, it still does not solve the ongoing need in communities like Hastings and North Platte. LB 1183 will provide funding to support the expansion of Heartland Health Center into Hastings and eventually North Platte. We have been working closely with Mary Lanning Hospital, South Heartland District Health Department, and community leaders on expanding Heartland into Hastings. And I will add, when we got the FQHC in central Nebraska, it was a toss-up if it was going to be in Hastings or Grand Island. Grand Island won kind of over, I think, the population side of things. And so there was always that promise to get into Hastings. And ever since I've started, they've not let me forget that we need to get to Hastings. So
we're working very hard with that. We have already identified a site that will allow us to bring medical, dental, and behavioral health services to the community, but that will require some capital funds to make that come to fruition. Likewise, North Platte is another community with a high need for a health center. There have been discussions with leaders in the community, and the health department previously submitted an application for federal funding for a new health center location, with no new funding at the federal level and no guarantee that there will be new federal opportunities anytime soon. LB 1183 provides the opportunity to bring healthcare services directly to North Platte. I moved from North Platte about 18 years ago to Grand Island, and I'm very well aware of the needs, even back then, that were in North Platte. Nebraska is at the crossroads when it comes to access to healthcare in rural Nebraska. LB 1183 is once in a lifetime opportunity to transform healthcare delivery and access to everyone, regardless of the population in their town, their health insurance status, or how much money they make. I would like to thank Senator Aguilar for introducing this legislature and urge the committee's support. I would be happy to answer any questions.
Any questions? Senator Dorn.
Thank you, Senator. Thank you for being here. You and the previous testifier both mentioned the fact that you brought this to or incorporated it with the schools or whatever. So exactly what, I guess, what are you looking at for a student, or are they referred to you, or what? How does the school connect to you, or you connect to the school?
So one of our biggest, I would call, community partners within Grand Island and our Ravenna clinic is the schools. So as part of a FQHC, we do a needs assessment. We have to do a new one every 3 years. And so part of the needs assessment did identify behavioral health needs of younger population. And so building that relationship with Grand Island Public Schools, we talked about where their greatest need was, and at that time was behavioral health. And so we kind of just went out on a limb and have selected 3 of the schools that are more of the minority population and where the Grand Island Public Schools had identified the biggest need, and have put behavioral health specialists in those 3 schools. We actually started with 1, an elementary school, and then we've expanded into 2 middle schools, and the ask to go into about 4 or 5 other ones. And we have a total of 22 schools with the Grand Island Public Schools. In Ravenna, same thing. It was kind of a talking with them because they weren't used. Ravenna has never, ever had behavioral health in the small community of 1,200 people. They've never had behavioral health. So when we first brought that, it was that stigma. But then as we started working with the school counselor, the school administration, and just slowly started going in, my provider is seeing about 12 to 14 school students on top of what he's seeing adult patients in Ravenna right now. And we did not expect it. So it just shows the need for that behavioral health service.
Thank you.
Any additional questions? Seeing none, thank you.
Thank you.
Any additional proponents?
Good afternoon.
Afternoon.
Good afternoon, Chairman Stenner and members of the Appropriation Committee. My name is Carson Sims, Karsensims, and I am a second-year law student here on behalf of the ACLU of Nebraska, where I'm a current law clerk. As you've heard today, LB 1183 seeks to appropriate federal funds allocated to the state of Nebraska from the Federal Coronavirus State Fiscal Recovery Fund to the 7 federally qualified health centers throughout the state in order to fund capital projects that are essential to the general welfare of Nebraska. These health centers have always been integral parts of the communities they serve. However, they are more important now than ever. First, we know that people of color across the country and across Nebraska have contracted and died from COVID-19 at rates alarmingly higher than whites. Additionally, people of color and women are more likely to be in low-paying or hourly wage jobs, making them more likely to have faced economic insecurities due to the pandemic and less likely to have had protections in the workplace or access to things like health insurance or paid leave. Specifically in Nebraska, it has been clear that those essential workers who we rely on to grow our food, stock our supermarket shelves, and work in our meatpacking plants, who are disproportionately women and Nebraskans of color, have been among the individuals hardest hit by the pandemic. These are the people federally funded health centers are serving in Nebraska. LB 1183 will address many challenges laid bare by the pandemic, especially in rural Nebraska and low-income communities, by helping to ensure all communities have access to high-quality health care. Legislative Bill 1183 will allow Nebraska to invest in capital projects that meet communities' critical needs in both the short and long term. Enabling these investments in capital projects will address the inequities which were displayed through the COVID-19 pandemic and serve thousands of Nebraskans for years to come. The legislature must use these federal funds to benefit Nebraskans in equitable ways. Women, people of color, people with disabilities, non-English speakers and communities, and many more need the legislature to support Legislative Bill 1183 and advance equity throughout Nebraska by allowing innovation and investment in their communities. For these reasons, the ACLU of Nebraska expresses gratitude to Senator Aguilar for introducing Legislative Bill 1183. And I will take any questions.
Questions? Seeing none, thank you.
Thank you.
Additional proponents? Any opponents? Anyone in the neutral capacity? Seeing none, would you like to close, Senator? Senator waves his closing. And there are there are 5 letters of support for LB 1183, and that concludes our hearing on 1183. We will now open on LB 1172.
Good afternoon, Chairman Stinner and members of the Appropriations Committee. I am Robert Hilkeman. That's ROBERTHILKEMANN, and I represent District 4, appearing to introduce LB 1172. The page is distributing a white copy amendment that will replace the bill. This is AM 1699. It makes a one-time appropriation of federal ARPA funds in the amount of $111 million with intent language that the department use $37 million in each of the next 3 years for the purposes listed at the bottom of the page 1 and the top of page 2. Providers of services to people with developmental disabilities took an extra special hit during the COVID, and the pain continues today. The providers who will follow me will give you specific examples of what they have and continue to go through. LB 1172, or now AM 1699, is an absolute example of what the funds sent to Nebraska due to the American Rescue Plan Act 2021 should be used for. Developmental disability is a 100% Medicaid funded industry, and providers of these services have been caught in a catch-22 for almost 24 months. Their costs increased, their revenue decreased due to the COVID-19 pandemic. People with developmental disabilities are among the highest risk population to diseases like COVID-19. Studies have shown that having developmental disability is the strongest independent risk for presenting with a COVID-19 diagnosis and the strongest independent risk factor other than age for COVID mortality. To safely deliver services to these people, space requirements required providers to spend funds that could not be reimbursed by Medicaid. Quarantined individuals could not come to facilities for services, thus denying providers to be reimbursed for those days, even though their fixed costs continue to increase. Wages for direct service providers are dictated by reimbursement rates. Current starting wages for these positions is about $13 an hour. Fast food restaurants are currently advertising for up to $20 an hour. The industry is facing a staff shortage of around 35%. These ARPA funds will allow providers to boost their starting wages in an effort to bring those workers back to being direct service providers. Thank you for your time, and I'll take any questions you might have.
Seeing none, thank you.
Okay.
Good afternoon. Thank you very much for having us today. It's a long afternoon. My name is Leslie Bishop Hartung, Leslie Bishop Hartung. I'm the president and CEO of the Autism Center of Nebraska, commonly known as ACN. I'm here today representing ACN as well as the Nebraska Association of Service Providers, or NASP, to testify in support of LB 1172. As a developmental disabilities provider, ACN has faced unprecedented staffing issues and financial losses, due in large part to the effects of the pandemic. Prior to the pandemic, we employed 170 people. Currently, we employ 144 people. This causes significant hardship in providing continuity of care to the individuals we support. Our pandemic-related shortage of frontline workers has been as high in my agency as 23%. On average, Nebraska providers are attempting to care for the most vulnerable Nebraska citizens with a 30 to 35% shortage of direct care staff. We are unable to attract qualified candidates, or in fact, any candidates, with the wages we are able to offer under the current rate methodology. The average direct support professional in Nebraska earns $13.27 an hour. Fast food restaurants in my neighborhood are offering $15 an hour to high school students. But we're not making hamburgers. We're caring for people, some of the most vulnerable citizens in the state. We're caring for people who require the supervision and supports of direct support professionals 24 hours each day. If we don't have staff, we don't have the ability to post signage that says temporarily closed. We must continue to provide these essential services and supports. We have dedicated staff at our agency that are saying yes to those requests for extra shifts. We have staff that are working 100 hours each week, and this is simply not sustainable. Providing quality care and supports to persons with autism and other intellectual and developmental disabilities can be exhausting, physically and emotionally, and we must have adequate staff to allow our existing staff to have a break. We must be able to offer scheduled and predictable staffing to those we support. We must be funded at a level to allow our essential direct support professionals to receive a living wage. I want to thank you very much as a committee for support of LB 893, which provides a 15% rate increase to providers. You might think that will solve these problems, but by itself it does not. LB 893, when put over our billings over the last several months, allows us to break even. We are operating at a deficit now. Even if we could, with LB 893, offer a small hourly increase, we would not be competitive with the many unskilled employment opportunities. And yet we ask for so much more from our staff. Clearly, without the passage of LB 1172, we will not be able to increase wages for direct support professionals in any meaningful way. LB 1172 will provide the ability to provide increases in hourly wages, allowing providers to recruit more qualified staff. We must have both of these bills to pass and work in tandem in order to effect the necessary changes to ensure the state of Nebraska meets its responsibilities to our most vulnerable citizens. I want to thank you for your thoughtful consideration to the care needs of Nebraskans with intellectual and developmental disabilities, and I thank you for all of your efforts to provide the funds necessary to attract and retain qualified individuals who understand the crucial importance of this work. Do you have any questions?
Questions? Seeing none, thank you. Afternoon.
Good afternoon. Thank you for allowing us to share some information with you today. My name is Laurie Ackerman. I'm the Executive Director of Ollie Center Incorporated in Omaha, Nebraska. It's LAURIEACKERMANN. Dear Chairman Stenner, excuse me, and Senators, fellow Senators, my purpose for being here today is both personal and professional. Professionally, I'm here to represent, as I mentioned, Ollie Center Incorporated and all the other agencies like us that provide services across the state. I urge you to support LB 1172 to keep services that require staff for people with intellectual and developmental disabilities available to those in need. All services need increases. Services that require higher staff ratios, as Leslie talked about, need increases, and services that work to reduce the need for greater interventions by providing the most person-centered community-based services, such as supported employment, also need increases. Notwithstanding the incredible challenges we have all faced the last 2 years as a result of the global pandemic, and we need to emphasize all DHHS services we provide, so Ollie Center Incorporated as an agency, lose money. The only way we were able to survive pre-pandemic is through the generosity of local foundations that believe in our mission and extensive fundraising. In that vein, some potential funders are hesitant to provide funding to us because their belief is that the rates paid by DHHS covers 100% of the cost of doing business for those services. Ollie Center Incorporated is a merged organization. The Career Solutions portion of our agency provides employment, residential, and community inclusion services. Aside from vocational rehabilitation funding that covers some of the supported employment services we provide, the bulk of our revenue for our Career Solutions Program services does come from DHHS. The other portion of our agency is the ARC of Omaha, where we primarily focus on providing services that fill particular needs not often provided in the Omaha metropolitan area. We do this through programs that focus on family support, mentoring, self-advocacy, and community integration, so going beyond just community inclusion, such as our First and Next Chapter book club programs, Best Buddies, and parent-to-parent programs, to name a few. The extensive amount of funding we have to obtain through foundation support and fundraising is laborious. It takes away from time and energy that we should be putting towards increasing the number of people that would benefit from our non-DD funded programs or to add other needed services and supports in our community. No DD funded agency should have to fundraise to cover state funded services. Simply put, the services we provide would be fairly compensated in any other realm of business and industry. For example, the state would not put out bids for electrical work to update the wiring at the state capitol and then tell the contractors that they will only pay 75% of their costs regardless of the bid. Well, I realize the state would most likely go with the lower bidder. Any bidding contractor would surely only put a bid in that would adequately cover their costs and labor. No one would take on a job where from the get-go they know they will in fact lose money. But without any bargaining means, we as an industry have to rely in good faith that rate increases will be built in to cover the rising cost of health insurance and starting pay rates for staff that are well-trained and have experience. The increases we have gratefully received over the years have been grossly outpaced by the cost of doing business. The DHHS funded services we provide have required increasingly complex levels of reporting, resulting in the need for all providers to invest in more dollars in accounting and compliance staff, as well as technology. This detracts from the ability to invest in hiring more qualified direct line staff. And in the end, I dare say it has not provided the overall quality, or has not improved the overall quality of what we do. It has simply improved the data the state receives from DD providers. In fact, I would argue it has diminished our ability to attract and effectively compensate staff, as has been shared, increasing the stress on all the staff up and down the line, while decreasing the continuity and effectiveness of services. To put it in blunt terms, our industry, I'm speaking nationally here, as a whole does not place the same value on our workers as it does on educators or healthcare workers, for example, where years of education or specific certification process is matched by the wages that reflect the knowledge and experience required to enter into the workforce. I know I'm running out of time, so as many others have attested to or will attest to, the pandemic has compounded the ability to staff an industry that already has high turnover among frontline workers. That takes me to why I'm personally here. I'm here to tell the stories of my siblings, Mike and Mary. My brother Mike experienced a difficult birth resulting in a traumatic brain injury. While not apparent at first, as he grew older, the impact that injury had became more apparent. Well, what little language he had acquired early on completely went away by the time he turned 3 years old. followed by the regression of other skills he had attained up until that point. While Mike could not speak verbally for the remainder of his life, he spoke volumes with his actions, and on those rare occasions, his magnanimous smile. Mike did not have an easy life. In fact, at varying times throughout his life, he experienced severe abuse at the hands of some staff on more than one occasion. While thankfully not a term that we would use today, he was diagnosed as having profound mental retardation. Though not officially diagnosed with autism, he exhibited many of the behaviors that would elicit such a diagnosis today. While living as a young man in a group home operated by a local DD agency, Mike sustained an injury so severe that he nearly lost his life. His primary staff person that lived at the apartment where Mike lived with 2 other young men with disabilities was the kind of staff you wish you could clone. I believe he had an education degree and chose to work in this industry. He understood Mike's needs, and Mike loved to see him as the staff. One weekend, however, the weekend staff member did not follow protocols and did not understand the level of fear Mike had with taking a shower. He always took baths.
Ma'am, if you could conclude, the red light's been on for a
Okay,
while.
I'm so sorry. Simply put, there's more in my testimony here, but basically the point I'm trying to get at is that we need to have well-trained staff who stay with us. You've heard about the high staff turnover. As Mike's life progressed on, he certainly had those kind of staff that could support him. But if we don't have the kind of staff that you would want to serve any member of your family, you never know when you might have a family member, a friend, somebody down the road who has a disability. We need to take care of our most vulnerable citizens. We need to have well-trained staff, and we need to have the funding to sustain that. Thank you.
Thank you. Questions? Seeing none, thank you.
Good afternoon.
Afternoon.
Chairman Stinner and members of the Appropriations Committee. My name is Matt Kosick, Mattkassik, and I am the CEO of Region 5 Services. I'm here today on behalf of the Developmental Disabilities, or DD, provider community, and as a member of NASP, the Nebraska Association of Service Providers. I'm testifying today in support of LB 1172. My organization, Region 5 Services, is the largest provider of DD services in the state of Nebraska. We support around 800 individuals with disabilities and have done so for almost 50 years. Our longevity is rooted in our diversity. We offer every service that a provider can, and additionally, our geography has also helped us through the good and the bad times, as we are almost evenly split between metro locations in Lincoln and 13 rural locations in southeast Nebraska. Based on this long fiscal track record, I can definitively say that the past 8 months have been among the worst financial outcomes our organization has experienced. During that time, our organization operated at a 6% deficit. Our revenues were down almost 15% compared to last year. Under normal conditions, our expenses would mirror the drop in revenue. However, with inflation and the high costs of overtime, our expenses were up 1% compared to last year. Region 5 Services is not an outlier in the DD provider community. In fact, most providers in Nebraska are experiencing a similar struggle. Now, I understand that this struggle is everywhere. It seems that most every business can't find staff, are cutting non-essential services, and paying overtime to the staff they do have. What makes the DD provider community different is that you, this committee and legislature, control our rates. We simply cannot raise our prices as most businesses can. That's why we need your help to appropriate funds to ensure the provider community stays healthy. LB 1172 would do just that. Not only would this bill help to steady our business, but it would also help us to improve and to invest in our future. DD providers are competing with all businesses to find workers. One unlikely competitor that has emerged is the state of Nebraska at the Beatrice State Developmental Center. The BSDC was facing critical staff shortages, and their administrators feared a catastrophic outcome if they did not act. So they acted and implemented a 20% wage increase in December. Now, our Region 5 Services Beatrice location is forced to compete with an $11.62 starting wage for comparable work. For reference, our starting wage is $14.03. Community-based DD providers are in the exact same situation that the BSDC was in. LB 1172 would help DD providers and the almost 5,000 individuals who we support in Nebraska. I would like to thank Senator Hilkeman for his dedication to Nebraskans with disabilities and for introducing LB 1172. I am available for questions. Thank you.
Any questions? Senator Erdman.
Thank you, Senator Tanner. So 37 million for 3 years, what kind of percentage increase is that over what you get now?
It calculates, if I'm doing the math correctly, it's about a 15% increase compared to where rates are now.
What we support you with now? 15%
Yes,
more.
so we are just one provider. Being the largest provider, we make up about 13% of all the revenue in the state system. Region 5 is we're just under a $50 million a year company. And I think it was mentioned earlier that our revenue is mostly Medicaid. So these funds, that is our primary source of income.
Okay, thank you.
Additional questions? Seeing none, thank you.
Thank you.
Good afternoon, Chairman Stinner and members of the committee. My name is Elena Shriver, ALANA-SCHRIVER, and I'm the Executive Director of the Nebraska Association of Service Providers, which is our state trade association for DD providers. Thank you for the opportunity to speak today on behalf of the people we support as well as employ. You've listened to requests for funding and the compelling evidence to support the massive need ad nauseum today. The time, attention, and action you are all dedicating to these issues is greatly appreciated and does not go unnoticed. You understand the chaos of the pandemic and the workforce crisis extremely well, so I'll not use any more of your time trying to convince you that the need is real. You know that it is. Instead, I'll echo Senator Hilkeman and focus on how perfectly DD services fit into ARPA eligibility and intent. I've submitted a copy of our ARPA eligibility checklist with my testimony, and as you look down the list, you can see that we check all of the boxes. People with IDD are at a higher risk of mortality due to COVID-19 than the general population, and as such, service providers have gone above and beyond responding to the pandemic in real time, 24 hours a day, 7 days a week, 365 days a year, relentlessly mitigating exposure and risks. We provide medical services as well as behavioral health care for people who often have dual diagnoses and high needs. The instability that results from staff shortages, for example, consolidating service locations, often exacerbates negative behaviors in people who thrive on structure and predictability, increasing the need for behavioral health support. Sometimes those negative behaviors include aggression towards already maxed out staff. Violence is often a result of stress. As a parent of a child with IDD, I can attest to the stress family members are under at home when outside support and respite are not available. DD services keep both individuals with IDD and their families safe and healthy. Utilizing ARPA funding to shore up DD home and community-based services has massive positive economic impact as well. In the same way that a caregiver of a small child needs affordable and reliable daycare in order to go to work, so do caregivers of people with IDD who require constant supervision. Every community in every town in every county across Nebraska has people with IDD and their families in need of our essential services. Our industry was financially rocked by the pandemic and is operating on reserves as a result, which has quickly become unsustainable and dire. Many DD providers are small businesses or nonprofits. All operate within the public sector. We rely on rates set by the state. There is no private pay or insurance to offset costs. The crisis facing DD services is precisely what ARPA funding is designed to address. There's no question of the need. There's no question of the value DD providers have in our society. The only question left is how much longer providers can hold out and what Nebraska will do when they break. Please don't let that happen. You have a lot of hard decisions in front of you in regards to ARPA. This should not be one of them. And if I may go off script, I do want to acknowledge that it may seem harsh that this bill excludes independents and shared living providers. There's approximately 900 independent providers in the state of Nebraska, but the majority of them are family members of people with IDD, and they only have that one person that they care for. Shared living providers are a roommate or a family that has someone with IDD living with them. So they were not as impacted by the pandemic as people with employees, people who have to go to day services, because you can stay home when you quarantine, and those shared living providers still get paid. So while both are dealing with the rising cost of inflation, neither independents or SLPs have the same overhead, capital investments, or employee-related expenses that the services specified in this bill do. So we were just trying to be cognizant and save the state as much money as possible. Independents are about 5% of the total state spend, but SLPs are 25 to 27% of the total spending. So by just focusing on the services that require staff, we were hoping to save the state as much money as possible and just put it where it's desperately needed. So I want to thank Senator Hilkeman for introducing this bill. Thank you for your time. I'm happy to answer any questions.
Any questions? You wouldn't have the number on congregate housing, would you?
I do not, but I could get that to you.
Thank you. Seeing none, thank you very much.
Thanks.
Hi, Senator.
Hi.
My name is Joe Valenti, J-O-E. Valenti, V as in Victor, A-L-E-N-T-I. I have to give a disclaimer here. I have to support this bill. Robert's my senator, so I don't have much choice. Plus, he just listed his house with my firm. Well, it used to be my firm. But anyway, I'm in total support of this bill. My concern is the same as I mentioned to you last time I was here and visited with you. How the money actually get to the DSPs. And in the past, and maybe in the amendment, which I haven't seen, it really directs that, but the legislature has the power to do that, to really make sure when there's a rate increase that it gets to the DSPs on a certain percentage basis. Now, I don't know all the formulas here that are being passed around on the 111 million, but I agree with the NASP and all the other speakers here today. But again, my concern is my wife is guarding the 3 individuals, 2 in Omaha that are with providers, and she can't share much with me, but I would say that even with the increased money, they've got to hire people. And I think to provide all these services, habilitation, a supported work environment, it takes people. And I'm not sure exactly how they're going to get them because it's a challenge. And back to BSDC, Matt, who I don't know, testified about BSDC. As I mentioned before, that was a union negotiated thing, had nothing to do with really Health and Human Services. They didn't have much control over it. But having said that, it was not in a catastrophic stage. And quite frankly, even with the wage increases, what it's done 2 things. It's helped retention and it's helped, therefore, turnover. They have been able to fill some positions, but as a 24-hour facility, it is very, very difficult to fill the positions that are necessary because people just don't want to work that 24-hour shift. Or I shouldn't say 24-hour, but from 10 to 11 o'clock till 7 o'clock in the morning. So it's still a challenge there also, by the way, but a very needed service. So I support the bill. I support the concept. My concern against it is DD overseeing how that money gets done. And in the past, senators, we've had studies after studies after studies done by very good consulting groups. And I'm just going to be really clear, a little derogatory. The department doesn't follow through after the studies have been done. And that's not my job, and that's not necessarily your job. That's Health and Human Services Committee, which I've already spoke to John Arch about also. So again, that's a little bit biased, but the money's just not getting used properly by HHS in all cases, in my opinion. Thank you. Questions? Thank you.
Thank you.
And I did support you.
Additional proponents. Any opponents? Anyone in the neutral capacity? Seeing none, Senator, would you like to close? Senator waive closing. There are 132 letters of support. Senator Hilkeman, you must have stayed up all night doing that. And 2 in opposition. 132. That concludes our hearing for today.
So did you have a good meeting?
My staff.
Oh.
Be done by 5:30.
Provider gonna be done by 5.
Wouldn't be done by 5, halfway through the afternoon.
I asked some of the same ones.
Yeah, we might be able to get them.
Stenner.
I wanted to tell a story about my dad that I kids as well.
Didn't promise the governor and
Wait, there you go.